from Spain. Good evening there in Malaysia. Can everyone hear me?
All right, so you're still waiting. We would appreciate your discussion with us. I really hope that this session is going to be a very active discussion so that we can clarify any sort of questions that we have in terms of our patients management.
And for those who would like to submit a question, please scan the Slido QR code display on the screen or on your table, or the event code 1640733. Alternatively, you may raise your hand if you would like to ask your question live. Once again, please join us when welcoming Prof. Martha. Over to you, Prof. Martha.
Thank you very much, dear colleagues. Good morning from Spain. It's 7:30 now here. Good evening there in Malaysia. Firstly, I would like to say that I'm really happy to join everyone today. First, I would like to thank also AstraZeneca for having me here, and I hope next time we can meet. So without any further delay, I was asked to try to answer this challenging question, I'd say. Are we keeping up with the evidence? And for this, I will raise 4 more questions. So, and to finish the talk, I will talk about the future, which is quite complex indeed, and then I'll have some conclusions. So yeah, I would like to start with, I think, a new concept that is I'd say a paradigm shift. I think this concept summarizes the major change occurring in COPD nowadays. For many years, COPD, as you know, has been mainly understood as a respiratory disease defined by airflow obstruction. Our clinical priorities were focused on improving symptoms, reducing dyspnea, and of course, improving lung function. But however, current evidence tells us that COPD is much more than that. COPD, as we know it, is associated with systemic consequences, cardiovascular vulnerability, and increased mortality risk. So therefore, our objective is evolving from simply improving how patients feel today to changing what happens to them tomorrow. The reason behind this change is that COPD generates a state of cardiopulmonary vulnerability, as we said. Several mechanisms contribute to this increased risk. Persistent airway and systemic inflammation may promote endothelial dysfunction and cardiovascular damage. Hyperinflation can negatively affect cardiac function by altering heart-lung interactions. Hypoxemia contributes to pulmonary vascular changes and CV outcomes. And finally, exacerbations act as acute inflammatory events that can trigger both respiratory and cardiovascular complications. So COPD should not be interpreted as isolated lung dysfunction, but as a condition where respiratory and cardiovascular systems are deeply connected. This is, I'd say, particularly relevant when we talk about exacerbations. Traditionally, exacerbations were considered as temporary episodes. Patients deteriorated, we treated them, and then they recovered. But we know that this concept is still incomplete. An exacerbation represents a period of increased biological vulnerability. It accelerates lung function decline, increases the risk of future exacerbations, leads to hospitalization, and is associated with CV events. In other words, an exacerbation should be considered a cardiopulmonary event. One of the most important predictors of future exacerbations is, of course, previous exacerbation history. However, this slide, I think it highlights an important clinical problem. And this problem is the waiting. Waiting for an exacerbation means accepting a preventable risk we can work on. And also, another important concept is that the absence itself of previous exacerbations does not mean absence of risk. In this large observational study, a significant proportion of patients who developed frequent exacerbations during follow-up had no recent history of exacerbations. So if we wait until patients accumulate exacerbations before acting, we may be accepting preventable risk. The challenge, I think, is identifying vulnerable patients before the next event occurs. So yes, I would say very, very strongly that every exacerbation matters. After first severe exacerbation in this classical slide by Sami Suisa, we know that patients requiring hospitalization, only approximately 50% of them were alive after 3.6 years. But the risk is not limited to severe events. Even a single moderate exacerbation has been associated with increased COPD-related and CV-related mortality. Therefore, exacerbation prevention is not simply about avoiding a short-term clinical deterioration. It is about protecting patients from future events and potentially changing their disease trajectory. So, second question of the talk. If exacerbations are prognostic events and COPD creates a cardiopulmonary vulnerability state, are we treating early enough? For many years, up until now, our approach to COPD treatment has been mainly reactive. We started treatment, we waited until patients develop persistent symptoms, recurrent exacerbations, or disease progression, and then we intensified therapy. This approach made sense when our main objective was symptom relief itself. But now, if our goal is preventing future risk, we need a different strategy. I would say a more reactive approach. So, walking back again to the new paradigm of COPD, we need to base it on a proactive prevention. Instead of waiting for clinical deterioration, we need to identify risk earlier. This means considering not only symptoms, but also exacerbation susceptibility, lung function impairment, inflammatory markers, and cardiopulmonary comorbidities. The aim is to provide the right treatment to the right patient before irreversible consequences occur. And how are we going to do that? Well, at this point, I think it's important to talk about GOLD. GOLD 2025, 2026, I'd say, has made a huge evolution. And this is reflected in the new recommendations. The changes in GOLD should not be interpreted only as modifications in treatment algorithm. I think, and this is my opinion, they represent a change in mindset. Lowering the threshold for high-risk patients reflects a more proactive approach. A single exacerbation should no longer be viewed only as a warning sign. It represents an opportunity for intervention. So yes, I think our goal for all physicians should be 0 exacerbations in our patients. What about for the follow-up and the treatment of our patients? The same concept applies during this follow-up. Management is increasingly based on identifying treatable traits and future risk. For patients who continue to exacerbate despite maintenance therapy, escalation decisions should focus on preventing additional events. Again, the objective is not only treating the current clinical status, but reducing the future risk. Another important objective in GOLD's guidelines this year is recognizing that some historical treatment patterns may not reflect current evidence, and I'm talking about patients on ICS/LABA. These patients that are remaining on this combination despite persistent symptoms or exacerbations. Current recommendations emphasize that treatment optimization according to patient characteristics and risk profile. So, I think this slide summarizes the key transition. As our treatment goals evolve, our expectations from clinical trials must evolve as well. Previously, demonstrating improvements in lung function and symptoms was enough. Today, us physicians are asking for more ambitious questions. Can treatment prevent exacerbations? Can it preserve lung health? Can it reduce cardiopulmonary events? Can it impact survival? The question is no longer whether our patients breathe better today. The question is whether we can change what happens to them tomorrow. So this brings us to the third question of the talk. The question, I would say, is no longer only whether our patients breathe better today. As I said, so can we answer if triple therapy has generated the level of evidence required for our COPD patients? As our understanding of COPD has changed, the type of evidence we require from clinical trials has also evolved. Historically, COPD trials mainly focused on physiological endpoints. Can we improve FEV1? Can we improve symptoms? And these endpoints remained important because lung function impairment is directly related to patient outcomes. However, today we expect more from COPD therapies. The clinical development program for BGF that we'll talk in a few slides reflects, I think, this evolution. Here we have Chronos and Ethos, and as you know, Chronos mainly address the question of optimizing lung function and reducing exacerbations in a broad COPD population, and whereas Ethos moved on one step further and evaluated whether triple therapy could influence outcomes related to prognosis. So diving deep in these two large randomized controlled trials, we'll point out some special characteristics. Chronos included more than 1,900 patients and was designed with lung function as the primary endpoint, assessing both early bronchodilation and trough FEV1. As key secondary endpoint, we had moderate to severe exacerbations. Ethos included more than 8,500 patients and focused especially on exacerbation prevention, with annual rates of moderate or severe exacerbations as the primary endpoint. And what is new about Ethos is that is the first trial to have as a key secondary endpoint all-cause mortality. So we can see a clear progression, I'd say, from improving physiology to preventing clinical events and to evaluating outcomes that may influence prognosis. When interpreting clinical trials, understanding the population, I think, is essential. Both studies, as we've said, included symptomatic patients with moderate to severe COPD who were already receiving maintenance therapy. Ethos enrolled patients at a higher risk exacerbation risk, requiring a previous history of moderate or severe exacerbations. Chronos, however, did not require a previous exacerbation history. In fact, approximately 3/4 of the population had no exacerbation history at baseline. And this is highly relevant considering what we discussed earlier. If we want to move from a reactive approach to prevention, we need evidence beyond the traditional frequent exacerbator population. Let's move on to the results of these studies. Chronos, as we said, provides an interesting message regarding early optimization. Despite the fact that around 74% of patients had no previous history of exacerbations, triple therapy significantly reduced the rate of moderate or severe exacerbations compared with LABA/LAMA. The reduction, BGF, achieved a 52% relative reduction versus LABA/LAMA with a rate ratio of 0.48. The reduction compared with ICS/LABA was numerically significant and was lower, but did not reach statistical significance. So I think the important message from Chronos is not only the magnitude of the reduction. The important question raised by this study is, should we wait until patients become frequent exacerbators before optimizing therapy? Chronos suggests that the risk modification may start earlier. Moving on to Ethos. Ethos, as we know, was designed to answer a different question in a population at a higher risk. Can triple therapy reduce exacerbations compared to dual therapy? And the answer was yes. BGF significantly reduced the annual rate of moderate or severe exacerbations compared with both dual therapies. The reduction was at 24% compared with LABA/LAMA and a 13% compared with ICS. These findings are clinically important because exacerbations, as we discussed earlier, are not isolated events. They are associated with disease progression, cardiopulmonary complications, and increased mortality risk. Now I want to stop on the key secondary endpoints, perhaps one of the most relevant discussions generated by this study. Historically, very few interventions in COPD have demonstrated an impact on survival. Smoking cessation, oxygen therapy in selected patients, and some non-pharmacological interventions such as rehabilitation. For many years, pharmacological treatment was mainly associated with improving symptoms and producing exacerbation. Ethos challenged this concept. In the final retrieved dataset, BGF showed a 49% reduction in the risk of all-cause mortality compared with LABA/LAMA. And of course, these results, I must say, have to be interpreted in the context of the study design. In the post-hoc analysis of ethos brings us back to the beginning of the talk. If COPD is a cardiopulmonary disease, we need to evaluate cardiopulmonary outcomes. In this post-hoc analysis from ethos, severe cardiopulmonary events were defined as a composite, including major CV events, severe COPD exacerbations, and non-malignant respiratory death. BGF reduced the risk of severe CP events by 20% compared with LABA/LAMA, and this supports the concept that reducing COPD exacerbations may have implications beyond the lung. I think the future of COPD management will probably require this integrated cardiopulmonary perspective. But again, why does preventing exacerbations matter? We need to close this circle. At the beginning, we said that the exacerbations should be considered cardiopulmonary events. Clinical trials have shown that reducing exacerbations is one of the most consistent benefits of optimized inhaled therapy. And the biological rationale, I think, is clear. Fewer exacerbations mean fewer inflammatory bursts, less cardiopulmonary stress, fewer hospitalizations, and potentially better long-term outcomes. Therefore, preventing exacerbations is not simply controlling COPD activity. It is protecting patients from what happens in the future. However, randomized clinical trials represent controlled settings. Patients are very selected, adherence is monitored, and follow-up is structured. So the next important question is, are randomized controlled trials translating into clinical practice? I think to demonstrate this efficacy, we need to know that clinical practice is always more complex. Patients are older, have more comorbidities, and adherence is different. So in other words, can we move efficacy to effectiveness? To address this question, I think that it's important to know that if benefits are consistent outside clinical trials. And this is why we need to read and analyze carefully the studies we find from real-world evidence. To address this question, real-world evidence studies provide complementary information. And here we have METOS and EROS study that evaluated patients with COPD in a large US database. The objective was clinically relevant, I'd say. After a COPD exacerbation, does the timing of treatment optimization matter? Patients initiated, in this case, BGF, and they were classified according to timing. Prompt initiation within 30 days after the event, the exacerbation, delayed initiation between days 31 and 180, and very delayed initiation after 180 days. So this study directly evaluates one of the main concepts of today's talk, which is, are we acting early enough? The results of this real-world evidence study showed that timing matters. Prompt initiation of triple therapy after an exacerbation was associated indeed with a lower rate of subsequent COPD exacerbations. Compared with delayed initiation, prompt therapy was associated with approximately a 26% relative difference in exacerbation rates. Compared with very delayed initiation, the difference increased to 31% approximately. This is consistent with the idea that an exacerbation represents a window of opportunity. The period immediately after an exacerbation is critical and should not only be a recovery phase, it should be a moment for reassessment and optimization. What about when we talk about the effect of delaying triple therapy initiation? This analysis reinforces the same message from another perspective, I'd say. Patients who continued on previous maintenance therapies after an exacerbation experienced higher subsequent exacerbation rates. The clinical implication, I would say, is simple. Delaying the appropriate treatment after a high-risk event may expose patients to additional preventable risk, and this is exactly the gap between evidence and implementation. This concept becomes even more relevant after hospitalization. A severe exacerbation requiring hospital care is one of the strongest predictors of future outcomes. In this study, the Mythos and Eros, patients receiving prompt initiation after a severe exacerbation had fewer subsequent exacerbations compared with delayed initiation. The reduction was observed not only for overall exacerbations, but also for severe hospital-based events. Again, the key message is hospital discharge should not be the end of an exacerbation episode. It should be the beginning of prevention. And importantly, the real-world evidence is moving beyond respiratory outcomes. Following the same concept discussed earlier, this study also evaluated CP events. Prompt initiation after an exacerbation was associated with a lower risk of non-fatal cardiopulmonary events compared with delayed or very delayed initiation. This is particularly relevant because more than 60% of these cardiopulmonary events were cardiovascular related. So once again, COPD management cannot focus only on the lung. The objective is reducing the global cardiopulmonary risk of our patients. Moving on to another study, another important aspect in real-world practice is not only which medication we prescribe, but also how treatment is delivered. Scopus Mazzi compared single inhaled triple therapy with multiple inhaled triple therapy in routine clinical practice in over 22,000 patients. The primary endpoint was time to all-cause mortality, and as a secondary endpoint, time to first occurrence of a severe cardiopulmonary event. This is relevant because inhaler complexity may influence adherence, persistence, and ultimately clinical outcomes. So in this real-world analysis, initiation of CIT with BGF was associated with the lower risk of all-cause mortality compared with MIT. The observed reduction was approximately 18%. Of course, as with all observational studies, these results should be interpreted considering the methodology and the potential residual confounding. However, they reinforce an important clinical principle, which is implementation. And this is very important for our patients. The best evidence-based treatment only works if patients can use it correctly and consistently. Similarly, single inhaled triple therapy was associated with a reduction in severe cardiopulmonary events compared with multiple inhaled triple therapy. Again, this supports the idea that simplifying treatment strategies may contribute to better real-world outcomes. In COPD, optimizing therapy means choosing the right molecules, but also ensuring effective delivery for our patients. And finally, we're moving on to the ARCTOS study. Real-world evidence also provides information on healthcare impact. Reducing exacerbations is important not only from the patient perspective and the physician perspective, but also from the healthcare system perspective. We know from the burden of COPD, it's still the third cause of death in the world, and hospitalizations remain one of the main drivers of COPD burden and cost. Therefore, strategies that reduce severe exacerbations may benefit at multiple levels: patients, clinicians, and healthcare systems. So now I'm moving on, I think, to the hardest part of the talk, and this is talking about the future. I would say, where are we today? I think we understand COPD risk better. I think we have evidence supporting earlier intervention, and we have real-world data that support this implementation. But the next question, I would say, is what comes next? We need to act early. We need to identify and act before irreversible lung damage occurs. We need to be precise in our prevention. We need to move from one-size-fits-all to personalized risk reduction. And we also need to start thinking about new therapeutic targets beyond symptom control and towards disease control. So I think the next revolution in COPD care, if we talk about COPD 2030, we do not need to be treating more severe COPD. We need to be preventing COPD from becoming severe. And for this, I must say, moving from the evidence, I need to thank AstraZeneca for all of the work they've put in this transition through the future for our patients. They have many programs that are working towards better medicine, precise medicine for our patients. We've talked about Logos, Ethos, and Chronos, and there are many studies that will be talked about in this summit. For your information, there is a new phase 3 randomized controlled trial coming, which is the THAROS, that will assess the effect of BGF versus double bronchodilation on cardiopulmonary outcomes and COPD. This is going to be the first RCT that it's going to evaluate, and I'm very keen on the results when they are published. And also, I would say that AstraZeneca is focused on novel strategic, I would say, therapeutics for our patients. And this is tozorakimab, which is a high-affinity human anti-IL-33 antibody that I think is promising for our COPD patients. And why do I say it is promising? Because in the LUNA program, there have been 4 randomized clinical trials that have targeted this molecule. And I proudly say that I myself have participated in 3 of them, Oberon, Miranda, and Prospero, and 2 of them have met their primary endpoint. So I have congratulations for all the centers and AstraZeneca that have made this possible for our patients. So now I would like to conclude, I would say, with a strong message. And this message is language matters. It shapes how we think, act, and treat for our patients. The words we choose to influence our clinical priorities and ultimately patient outcomes have a great impact in our clinical practice, in healthcare providers, and in our patients. We need to stop using outdated language. We need to stop talking about lung disease. We need to stop thinking of exacerbations as episodes because they minimize their prognostic significance. We need to stop focusing on just symptom control as the main goal. We need to stop doing a stepwise escalation, and we need to stop having the patient as a passive recipient. We need to use a progressive language, be more proactive for our patients. We need to talk about cardiopulmonary disease. We need to talk about exacerbation as prognostic events. They are our myocardial infarction. When I talk to patients, I tell them that having an exacerbation is a lung attack. This represents risk, and it represents mortality. We need to start talking about risk reduction and prevention as the goal. We need to also be focused on early optimization based on risk, and we need to have the patient as an active partner to make decisions, good decisions for the care. So updating our language is more than semantics. It reflects the evolution of science and drives better decisions for our patients. So 6 bullets for this talk. COPD should no longer be viewed only as an airway disease, but as a cardiopulmonary condition associated with risk of exacerbations, CV events, and mortality. Exacerbations are not isolated respiratory episodes. They represent high-risk events. The goals of COPD management have evolved from improving symptoms and lung function to preventing exacerbation, preserving lung function, and reducing future risk. Evidence from pivotal triple therapy trials has expanded our expectations for inhaled treatment, demonstrating benefits beyond bronchodilation, including exacerbation prevention and impact on clinically meaningful outcomes. Real-world evidence supports the translation of clinical trial benefits into everyday COPD care, our care, and the future of COPD care will be driven by earlier intervention, precision prevention, and therapies aimed at modifying the course of the disease. Thank you very much, and I will be happy to answer any questions by the audience.
All right, thank you very much, Prof. Marta, for that insightful presentation. We do have the next discussion, another topic, Prof, but I do hope that you can stay on the line for us to have the Q&A session after this particular talk by the other 2 speakers. All right, next I would like to invite Associate Professor Dr. David Sim and Dr. Hayley Rossi to share their perspectives on 2 sides of breathlessness, a cardiopulmonary conversation. It's my pleasure to introduce to you Associate Professor Dr. David Sim. He's a heart failure and transplant specialist trained in the Alfred, Melbourne. He also serves as a senior consultant at the Sing Health Duke NUS Transplant Center and an honorary visiting consultant at Dover Park Hospice. He previously led the National Heart Centre Singapore, serving as a past president of Heart Failure Society and as deputy head of cardiology. He is a national leader for Singapore in major global heart failure trials, has published on biomarkers, phenotyping, and outcomes across heart failure syndromes.
As for Dr. Heli Rosie, she is a respiratory physician with fellowship training in respiratory medicine across major Malaysian centres and an advanced fellowship in lung disease and transplantation at UK, with a strong focus on interventional pulmonology. She contributes to service development and MRCP PACES training, has presented award-winning work at EPSR and MTS on bronchoscopy and pleural interventions. And she's also an active member of MTS, MABIB, ERS, WABIB, ISHLT, and MST.
Please join me in welcoming our speakers. Over to you, Prof. David and Dr. Haley.
All right, thank you, Dr. Afida and Dr. Teo, for the kind introduction. Allow me to use the rostrum because if I sit, I may not be able to speak well. So yeah, the task, good afternoon, everybody, and welcome to the Breathe Summit 2026. The task that was given to Prof. David and myself is actually to have a debate on COPD and cardiovascular disease. Come on, let's be real. What is the chance that I am going to win this debate against Prof. Sim? So, a safer and a smarter alternative is actually to present a case, and then we'll leave you as the judge, and we'll discuss this case together. Sounds safer to me to survive. All right, but anyhow, I am very honored today to be able to share the stage with our renowned cardiologist, Prof. David Sim. So I shall get the ball rolling by presenting a case on COPD first. All right, so let's have a look at my patient. So this is a 55-year-old gentleman. All right, a 60 years smoking history, diagnosed with COPD in 2010, 16 years ago. He also has metabolic baggage of type 2 diabetes, hyperlipidemia, and hypertension. If you look at the lung function, there are two lung function readings, 28 and 2024. There's plummeting FEV1 from 1.8 liters down to 1.3 liters, which is 42% of the predicted value over the years. So that's actually a drop. And there's no evidence of hyperinflation, but there's definitely air trapping as well as a reduced gas transfer. So I would like to bring all of you back to 16 years journey of this patient having COPD diagnosed and treated. I would like to, if you look at this timeline and also this heat map, what we can see that we can divide it into 5 eras of COPD, and I will go from one era to another. So in era 1, early diagnosis, he actually presented multiple times to the emergency department for an exacerbation. It wasn't severe enough to warrant admission, but he had 9 emergency visit exacerbation within 8 months window. And despite that, he was discharged every time from the emergency to continue his follow-up at the health clinic and to continue Sabah-Sama PRN TDS combinations. So that's happening around 1 to 2 years. And of course, as the disease progressed in 2011, the disease progressed, his symptoms become more severe, exacerbation getting worse, so he warranted admission. So during one of the admission, he was initiated on ICS LABA, and on subsequent admission for exacerbation and bad symptom control, LAMA was added on in his regime. So he was on triple therapy once upon a time, before Gold suggested it recently. So not surprisingly that he felt better after that. The disease remained stable, he felt better. So what's next? Guess what's next? Most of our patients, once they get better, they forgot to come and see us. So he defaulted from 2014 to 2017, back to over-the-counter self-purchased Sabah-Sama combination. All right, and also he works as a lorry driver. Buying over-the-counter medication works better for him rather than coming to the specialist clinics. So predictably, in 2017, he came to us with clusters of exacerbation because of poorly controlled COPD, not on proper medication for many years, for 3-4 years. And at that time, his symptoms has forced him to actually change his job from a lorry driver to a workshop foreman, which is less energy demanding. All right. He also, at that time, has stopped smoking. So once he is back to us, he was admitted to the medical ward, being under general physician care. He was reinitiated on ICS LABA, and because of multiple admissions and exacerbation despite ICS LABA, eventually in 2020, he was referred to a pulmonology to take care of his COPD problem. All right, so once he was with pulmonology, he was initially in 2020 changed from ICS LABA to LABA-LAMA combination, and later in 2023, after goal 2022 suggests ICS initiation, he was added on ICS. All right, so despite being on triple therapy, we know he had multiple admission, multiple exacerbation, and of course, a lot of loss of lung function. So despite now he has been referred to pulmonary rehabilitation, he has stopped smoking, he already on triple therapy, his disease burden remained high, his CAT score ranging from 24 and peak at 31 with MMRC of 3. All right, so this is him now. If you look at this diagram, this is mainly showing his medication that he has been on for the past 16 years. All right, and also not only in terms of pharmacological treatment, he also has demographic and social changes. He has to switch his job, and then he stopped smoking. That's good, but despite that, he is still a frequent exacerbator phenotype characterized by stagnant severe symptom burden despite 16 years of progressive pharmacological escalation and lifestyle intervention. All right, so he presented, so that's not the end of it. He presented last year, June, with another episode of exacerbation, productive cough, runny nose on progressive breathlessness for 4 days. He had rhonchi on auscultation, and CRP is elevated. X-rays mainly show hyperinflation. So he was treated as an infective exacerbation of COPD, was started on piperacillin and tazobactam, given corticosteroids, regular nebulizer, chest physio, and he was discharged home. Just before he was discharged home, he was changed from multiple inhaler triple therapy to BGF, budesonide, glycopyrronium, and formoterol, single inhaler triple therapy. So just a few weeks ago, when he came back to our clinic 1 year, after 1 year being on single inhaler triple therapy, his CAT improved. It has improved, but it is still high, from 31 to 27 to 20. MMRC is still 3. All right, he actually has self-nebulizer at home. Despite all the advice, he refused to stop. But what we can track is that the need for self-nebulization has markedly reduced from 2 to 3 times every day, and now it's just 1 or twice a month. We have strongly advised him against it, but he never listened. He never listened then, he would never listen now. So yeah, so last exacerbation was a year ago. So looking at this clinical progress, we can see how pre-triple therapy, patient's CAT score, symptoms burden is high, that has improved after initiation of triple therapy and continue to improve after initiation of single inhaler triple therapy. All right, but it doesn't change the current phenotype and status for which he is an uncontrolled frequent exacerbator with high symptom burden, MMRC of 3. All right, and with I think with maximum pharmacological and non-pharmacological management. So this is his disease trajectory from 2010 to 26 based on the management, and what we can see is that actually a complete exhaustion of both intervention that still fail to break the persistent symptom burden or even halt an acute exacerbations. So I would like to pass the mic to Prof. Sim for the next case presentation.
Thank you, Hayley. I'm not sure why I took on this. I realize I'm the only cardiologist in this room, tackling all the respiratory, but I still do my best, all right? Trust me, even I'm the only cardiologist, I won't go easy on you. So I'm here to present the other side of the story, to breathlessness, two-sided. So of course, as a cardiologist, I'm going to show you a case of a cardiac patient with breathlessness. So again, here we have a 9-year history of a case of progressive acute coronary syndrome. You can see, I'll go a bit in detail later, how progressively over 9 years, the ejection fraction has from normal 71% had all the way deteriorated to less than 50%. So this is the clinical trajectory of my patient I'm going to present. What started off in 2017 with an ejection fraction of about 70%, first time diagnosed with triple vessel disease. And you can see 2019, the patient had early revascularization to stabilize him. So we had some success in the initial stage. But subsequent years from 2020 onwards, that was when the things took a turn for the worse. Ejection fraction start to deteriorate. You're talking about 50%, very gray zone, almost down to what we call impaired cardiac function. And that's when he started having non-cardiac kind of condition as well. And now what is happening in this patient is end-stage progression. You're talking about ejection fraction of 32%. That will be classified as heart failure with reduced ejection fraction. And for me as a cardiologist, for any patient with acute coronary syndrome, coronary artery disease to progress to reduce ejection fraction less than 35%, that is bad news for the patient. Heart failure for us as cardiologists is just like a CKD patient progressing to end-stage renal failure, recurring dialysis. So this is for those of you who are interested in the coronary anatomy, how over the years, from a triple vessel disease, we have progressed to the stenting of the patient. So you can see from the, initially the LAD being affected to subsequently the CIRC, the RCA, all being, enrolled into the so-called blockage as well. And again, the infarction cluster 2024, that's when things really take a hit for this patient. Within the same year, you can see here 3 events from April all the way to December in the same year. He had a few acute coronary syndrome, the NSTEMI, and then subsequently, we tried to open a blood vessel. We were a bit successful in November, but in December that year, we couldn't do, You had to understand that sometimes with coronary artery disease, not every time we are so lucky we can get a vessel open up. And of course, with all this insult, the multiple infarction, the multiple heart attack, just like what you have in COPD, a lung attack, this patient heart took a big hit, eventually reprogressing to end-stage, now we have what you call severe heart failure, though currently the ejection fraction is 32%. To give a context, what is 32%? Once it's below 35%, we will recommend the ICD for the patient because they are more prone to sudden cardiac death as well. And of course, this patient starting in 2025 now are presented ED for breathlessness as well. So not to forget, it is not just a lung. The heart condition can cause breathlessness. In fact, a lot of time, the dyspnea between COPD and our patient heart failure can be very hard to differentiate. And to make matter worse, in March 2025, this patient started having fainting spell, cardiac syncope. When I see somebody with a poor ejection fraction coming to me with syncope, the back of my mind is this guy having arrhythmia? Is there ventricular tachycardia that's happening? So there must be serious consideration given to not just cardiac drug, but also to the consideration of ICD for this patient. So this is current medication for a patient. Antiplatelet, I'm sure all you are familiar with anti-angina drug as well. Of course, we need to get an LDL treated for this patient. So it's on rosuvastatin and ezetimibe. And of course, heart failure therapy such as RAS inhibition and beta blocker is also put on board for this patient because in less than 1 decade, from what is a normal heart function, 71%, it has gone all the way down to severe 32%. Now, again, this is just a summary of 2017 to 2026 for this patient, so I'll not elaborate more on that. I just wanted, at the end of this discussion between me and Haley, a COPD patient with, multiple episodes of breathlessness and a cardiac patient from acute coronary syndrome to advanced heart failure now. Who do you think is the sicker patient, all right? It's okay, if you tell her to vote for cardio, you can break my heart. So can we have the Slido up? Yep. Haley, it's looking very bad for you now.
Yeah. I told you, this is not even a debate and I lost that bad. Just imagine this is a debate. So yeah, discussion is a way safer to go. Oh, here my supporter, thank you. Slowly but surely.
Slowly, yeah, creeping out to passing.
We should actually hide the results because they're trying to make it 50-50, making it debatable, is it? All right. So the online attendees can also vote on Slido. And how long this voting would last? Can we stop? Can we stop voting? Can we? All right, I give the honor to Prof. Sim to reveal the results.
Okay, so what you can see here is about 60% of you roughly think that it is ACS patient, with the breathlessness, the sicker patient. What about 40% of you think it's COPD? Again, there's no right, there's no wrong. But unfortunately, for all in this room and all online, all of you are wrong. Because why do I say so? Can I go back to a slide? It's actually the same patient that we're talking about, all right? So both of us has presented the same patient for both COPD and acute coronary syndrome. For those who are sharp, you will pick up that the medication list for the patient with cardiac exactly the same like what I presented, right? Of course, I'll hide the inhaler from you. If not, you'll find out, right? So this is what we are talking about in the last, from our first speaker to now, that cardiopulmonary should be seen as, a disease entity, all right? So it's very common for me as a cardiologist to see patients coming in my room with COPD. Same for Haley. I'm sure a lot of our COPD patients were coronary artery disease, heart failure as well. So with that, I'll pass back to Haley again for the next few slides.
All right. Thank you, Prof. So, welcome to the cardiopulmonary collision, all right? So there are no two separate patients. This is a single 55-year-old gentleman with 60 packed years history. What all of us just witnessed was the exact same clinical reality viewed through two completely different specialist lenses. All right? So again, we look at the combined timeline. It's going to be clearer here when we look at August 2028. All right? Where a respiratory flare is followed by an unstable angina just 2 days after. And move forward to November 2023, where a respiratory admission for an exacerbation followed by unstable angina emergency department visit few days later. And of course, a respiratory crisis in March 2023, leading to a cardiac syncope in March 2025. So from this information, we can see that even two procedures for primary PCI was cancelled because patient keep on coughing. So the heavy burden of the disease actually caused patient to not be able to go through a procedure that actually is important for the heart. All right, so I leave then to Prof. to continue.
So thank you, Haley, for that. So as you can see, COPD exacerbation, why it lead to cardiovascular event and decline in the patient health and well-being. Again, remember what our all so far, all the speaker, what we tell you is, remember the word CPR don't just stand for cardiopulmonary resuscitation, it also stands for cardiopulmonary risk. A lot of time with COPD exacerbation, you're talking about an upsurge in the inflammatory drive. We are talking about increased inflammation, all that. It not only affects the lung tissue, it will impact on cardiac as well. Cardiac disease itself is also for our atherosclerosis heart failure, seen as a inflammatory disease. So this surge during a COPD attack or what we call a lung attack can also affect the endovascular bed as well, leading to increased risk of acute coronary syndrome, a prothrombotic state as well. And you can see, again, I emphasize that, in COPD, you have inflammation of the lung. For us as a cardiac physician, we see the inflammation in the vascular bed and in the cardiac tissue. And don't forget, for the CKD patient, you're talking about inflammation in the renal tissue. Also, the gastroenterologist now also seeing things like the fatty liver as a inflammatory disease in the liver as well. So this whole continuum of cardio, kidney, metabolic, and pulmonary is a whole continuum where it's a systemic inflammation affecting all the tissue. Do not see them as separate issue. Of course, for me as a cardiologist, with the hyperinflation for COPD, the lung from the left and right side squeezing our heart, not a good situation. Already in heart failure, you're talking about reduced cardiac output. Now it's going to be worse with hyperinflated lung. And of course, if you allow the patient to have multiple lung attack, multiple COPD exacerbation, the hypoxia that's going to induce will cause pulmonary vasoconstriction, which in turn will produce a lot of strain on the right heart. Given enough time, the right heart will go into right heart failure as well. Now, when after a COPD exacerbation, regardless of whether moderate or severe, you can see here, you're looking at immediately there's a very great risk in the next 1 or 2 weeks of a cardiovascular event. And these are not benign cardiovascular events. You're talking about acute coronary syndrome, stroke, heart failure, life-threatening arrhythmia, all right? So whenever a patient has COPD exacerbation, you are not just talking about getting them, to have less breathlessness, about quality of life, about treating the respiratory part. You also need to address the cardiovascular part as well, because in the next 1 or 2 weeks, they are more likely to get a cardiac event. And you can see that this event don't just go back to baseline. Even up to 1 year, the baseline is still elevated. It will never go back to the same baseline. And again, you can see that, very commonly, that's why I'm saying that you see among the COPD patient, the cardiac event. Conversely, among the cardio patient, a lot of them have COPD. So a lot of the COPD and cardiovascular disease patient are shared pool between me and our respiratory colleague. And again, cardiovascular related comorbidity, it is sometimes make it difficult to, diagnose. What I mean by that is, a lot of times, COPD and heart failure or cardiovascular disease, they present the same dyspnea, fatigue. These are all very common disease and the so-called presentation of both disease. So you need a lot of so-called high level of suspicion. So what I will propose is treat both group of patients. If a patient has both cardiovascular and COPD, treat both conditions, to the maximum that you can do based on the guideline. If I, as a cardiologist, I already maximize all my therapy for my cardiac patient, they still don't behave, they still have breathlessness, I would then think, is there something else going on? Is there COPD that can account for the symptom? Should I refer to my respiratory physician? Because at the end of the day, they will still need some form of spirometry for that, all right? So again, a quick summary, when we suspect COPD in patient stable angina or stable CVD, again, maximize your medical therapy. If need to, send them for angiogram, optimize the so-called revascularization. After doing all this and patients compliant, they still have symptoms suggestive of COPD, do refer to respiratory much earlier. Same thing with heart failure. After I've done my part as a heart failure physician, I've given all my drug for heart failure, the diuretics are all optimized, and clinically, I am very sure the patient is already euvolemic. He or she is still having symptoms suggestive of, COPD. Again, refer to my respiratory physician earlier as well. I think this is what the primary care should do as well. Cannot just refer to me as a cardiac and say, okay, it's not a cardiac issue, and you stop there. So the key word is nowadays is, just like what we do in cardiology, what we do with heart failure, all this is, when you encounter a patient with COPD, do not have the kind of old concept. Let's treat one step two. Say, let me start with a single inhaler. It doesn't do well, start a second inhaler and a third inhaler. That's not the way to go forward, all right? Because I put it bluntly, the next COPD exacerbation may be the last event for the patient. These patients are, very prone to cardiovascular event as well. So you should target all the different pathways as soon as possible. A COPD patient will not come to you and just say, I have a, airway issue or I have inflammation issue. They have all these issues. So why not leave all the pathway, addressed rather than leaving some being untouched? So again, this is what we should approach a patient with combined cardiovascular disease, COPD. For the respiratory side, we have all the triple inhaler. We have things like macrolide, mucolytic agent. For me as a cardiologist, my job is to make sure the ACE inhibitor, the beta blocker, statin, and the antiplatelet is all on board. And of course, it's a shared responsibility between the respiratory and cardio to encourage smoking cessation. We have our cardiac rehab, respiratory, you have a pulmonary rehab. And of course, we encourage them to have vaccination. Vaccination nowadays is recommended for both chronic cardiac disease and also for COPD. With that, I hand it back to Hayley again.
Thank you, Prof. So the timing of our intervention matters immensely. If you look at this EROS trial data, it shows that initiating promptly, triple therapy promptly compared to delayed or very delayed plays a very big role. So look at our patient. He was eventually on triple therapy, but it was very much delayed. So if you compare, there's 24 to 30% relative difference observed if you actually initiate triple therapy promptly rather than very delayed. So also similar, it also shows that prompt initiation of BGF actually reduce a non-fatal cardiopulmonary event up to 16 and 17.5% from the MITOS trial. So this is again from, this is a powerful results of ETOS trial mentioned by Prof. Mata just now. So it BGF compared to LABA-LAMA combination reduced mortality, all-cause mortality by almost 50%, 49%. And this is mirrored in the real-world evidence, Scopus-Mazzi. It shows that further reduction of 18% from all-cause mortality from single inhaler triple therapy compared to multiple inhaler triple therapy. And also, post-hoc analysis, ETOS trial shows 20% relative reduction in severe cardiopulmonary event if in group of patients with BGF compared to dual therapy. So again, this brings us to our final conclusion, supported by our national consensus panel. This is an urgent unmet need of early optimized management of COPD to reduce the risk of cardiovascular events and premature mortality. We can no longer afford to treat the heart and lung as two separate entities. So we have to look at it as a whole entity by itself. So we need to collaborate, identify patients with high risk overlapping risk, and of course optimize their dual pathway, the both disease together. Thank you very much.
All right, thank you very much, Prof. David and Dr. Haley, for that comprehensive and engaging discussion. May I kindly invite both speakers to remain on stage for the next sessions. And now let's welcome Prof. Mata back to the stage for our Q&A session. And once again, for those who would like to submit a question, please scan the Slido QR display on the screen or on your table. Alternatively, you may raise your hand if you want to engage more. So we will now open the floor for questions.
Please do take this opportunity to ask your question. Yeah? We have a very expert panelist here, particularly my Haley. I know her very well from my training days. Yes, please. We got one question.
Can triple therapy be initiated at the time of diagnosis of COPD without waiting for eosinophilic count?
So, who is it?
I think any one of you, particularly Haley, I think, or Prof. Mata, sorry. Shall we open the question to you? Do you want me to repeat the question?
I think I heard it, but I missed the last part. It was, can we initiate triple therapy on diagnosis without?
Yes, correct.
Last part.
Without the eosinophil count. Without knowing the eosinophil count, do you reckon we can start the triple therapy during acute exacerbations?
I would say no. We know that ICS has a big impact in our patients, but I think one of the most safe pieces of evidence we have is the answer our patients have to the ICS part of the inhalers when we have the eosinophil count. But if the patient is admitted, for example, I would say in Spain, we always have an eosinophil count with the hemogram. So I think it would be easy. If the patient has more than 100 eosinophils, we can safely start the triple therapy. But if we don't have that count, I would put the patient on double bronchodilation.
Do you mention 100 cells per microliter, Prof?
Yep.
Because, yeah, I noted that, thank you. Because sometimes patient who comes in with acute exacerbations, they would straight away be given intravenous hydrocortisone, for example, steroids, which may actually suppress the counts. If we look at the GOLD guidelines, it does actually mention that the cutoff is about 300. So you are taking it as 100, Prof?
No, once the patient has been diagnosed of COPD, the cutoff of the eosinophils for the follow-up lowers. So I would say if we have a patient that has been diagnosed with COPD and he has an exacerbations, we don't need the 300 count. That's just for the initial visit.
Okay, thank you very much.
Thank you, Prof. Mata. How about Dr. Haley? Would you like to add on anything?
All right. So there are going to be few situations where patients get diagnosed with COPD. Sometimes they come with symptoms, they come to your clinic, you get to do spirometry, then there you go, you get a diagnosis of COPD. Sometimes they presented first time in their life to you with an exacerbation already. With 10, 20 years history of smoking and phlegm production, it was undiagnosed. That's quite a common scenario in our practice. So usually, I think even in primary care or in an emergency department, when patients come with a wheeze or rhonchi, they are given immediately IV hydrocortisone even before the blood takings. So that can actually suppress the eosinophil, like what Dr. Afida said. Yeah, that can suppress the eosinophils. Again, looking back at the patient as a whole, I would say, prompt initiation, of course, the best. Delayed, we prefer prompt initiation rather than delayed. But delayed is better than never. If we are not confident, we don't have eosinophil levels at the time of exacerbations, or the eosinophil levels is low at the time of exacerbation, and we doubt this may not be due to steroid, maybe he's non-eosinophilic COPD anyway. Yes, we can start with dual therapy, but later, when patient come to the clinic, when he's more stable after the exacerbation without steroids, we can always repeat the eosinophils and consider adding on ICS. Or maybe that patient have a previous eosinophils levels, not that admission. It's already high. Maybe he came for something else, not because of exacerbation. It's already high. There's already an indication to start ICS. Of course, eosinophils is very important before starting triple therapy, but back to our clinical situation, where is this patient coming from? If the eosinophil is low during a clinic visit, maybe it is low to begin with. But during an exacerbation with IV hydrocort, there is a risk of suppression from the hydrocort. We may want to relook at that again during the next visit or so on. That's my opinion on that.
Correct. I think I have to highlight that the fact that you can always go back to your old blood test rather than just depending on the current blood test that the patient is admitted with. So worthwhile looking back.
Right. I think we still have some time, about 3.5 minutes. So let's move on to our Slido, another question. So we have the first question. In reverse, after an ACS, will worsen the COPD lung function and increase exacerbation? I think Prof. Sim?
I have a look at the screen. There's 3 questions, I think all directed against me. I will answer all 3. The first is, yes, definitely if you have COPD exacerbation, it increases your cardiovascular so-called, it will increase your cardiovascular risk. But I think conversely is true as well. If a multiple cardiac event, where we had drop in the ejection fraction, we know our chronic heart failure patient, they will have decreased reserve as well. They are more prone, just like your COPD patient, to infection as well. So that will, I think, and don't forget, acute coronary syndrome and a acute decombinant heart failure is also a inflammatory, acute surge in the inflammatory level as well. All those cytokine, everything that will, I think, predispose the patient to further COPD deterioration as well. All right. Second question, I know running out of time, is which cardioselective beta blocker should we be using? Very simple. For us in cardiology, especially heart failure, the current beta blocker is very beta-1 specific. So drugs like bisoprolol or nebivolol are very beta-1 specific. We have no concern. If I do come across a patient, not just COPD, even for asthma, we are very comfortable as cardiologists to use the beta-1 specific agent, because not forget, all these beta blockers are very essential for our cardiac patient. In fact, among all the heart failure drugs, beta blocker has the best mortality benefit. All right, so that I think will answer the question of beta blocker. And last one, I just, before I hand over, acute heart failure, when should we start COPD treatment? Actually, there's no contraindication. The patient come with acute heart failure. Once they can cope with the inhaler, after, for example, 24, 48 hours, you can just start. The respiratory physician in my hospital will be, starting a triple therapy while I do my work as a cardiologist with my medical therapy for the heart failure. As long as it's first 24 hours, sometimes they'll be panting for air, really gasping, on oxygen. It may be a bit hard for them to do the inhaler technique. But otherwise, after 24, 48 hours, go ahead, start your triple therapy.
Okay, the next question is for Prof. Martha, if you don't mind. The question is, in patients who are having COPD screening program or going through that program or was noted to have early COPD changes and who are asymptomatic, which treatment do you reckon should be initiated for this group of patients?
I don't know who did that question, but it is a very good question. And I would answer with another question. In Spain, we do not have screening programs for COPD patients. Do you have them in Malaysia? I would say this first. And then what treatment options are available? In Spain, we are lucky enough to say we can give patients whatever we want. So if it is an asymptomatic COPD patient with no exacerbations, I would recommend ALAMA. And if the patient didn't have exacerbations, but was mildly symptomatic, I would say with an MMRC above 2, I would say double bronchodilation. And I would also focus on treatable traits. If the patient has emphysema or shortness of breath during exercise, I would recommend rehab. Of course, I would say vaccination. I think this would be it.
All right, I guess I just clarify. Oh, time is up. I think time is up to make a comment. Just very quickly, I guess in Malaysia we don't have a screening program per se, but I guess we are very good in taking history from our patients. So I guess if, let's say, they come in with significant smoking history, for example, they might actually be referred to spirometry for assessment. So I guess that is where, this early COPD may be detected earlier. Okay, thank you.
Right, I think we are running out of time. Good questions, good discussion. Thank you so much, Dr. Haley. You may take your seat while Prof. Sim, please remain on stage.
All right, let's proceed to the next session, Real-World COPD Multidisciplinary Management from Crisis to Control. I would like to invite Associate Prof. Dr. Wong Chee Kwan, Dr. Muhammad Arif Muhammad Zim, and Dr. Jaya Munaswara to join us on stage, please. All right, I'm glad to introduce to you Associate Professor Dr. Wong Chee Kwan. He's a pulmonologist and academician who has previously leads the Respiratory Medicine Division. He also chairs the UMMC Tuberculosis Committee, contributes to National TB Clinical Practice Guidelines, and serves on professional committees within the Malaysian Thoracic Society. His research spans across clinical and implementation domains and support from national and international funders. As an active educator and mentor, he supervises postgraduate training, develops service innovations such as RED COPD and pulmonary rehabilitation, and frequently speaks at national and international meetings on respiratory care and health system improvement.
As for Dr. Muhammad Arif, Dr. Arif was formerly an associate professor at UITM's Faculty of Medicine and head of the Internal Medicine and Respiratory Unit at Hospital Al Sultan Abdullah UITM Puncak Alam. Dr. Arif currently serves as the president for the Malaysian Association of Bronchology and Pulmonology, better known as MABIP, and he is also the head of respiratory services for KPJ hospitals across Malaysia.
Dr. Jaya Munaswara is a leading clinical pharmacist specializing in respiratory medicine and currently serves as the head of pharmacotherapy services at Hospital Pulau Pinang. He holds a PhD from USM and completed a specialized fellowship in severe asthma at Singapore General Hospital. Notably, he is one of only 2 pharmacists worldwide appointed to the WHO COPD Guideline Development Group. As the National Preceptor for the Malaysia Advanced Clinical Pharmacy Program, Dr. Jaya holds key leadership roles within the Ministry of Health and serves as a vital advisor to the Malaysian Thoracic Society MTS and Asthma Malaysia. He has co-authored multiple national clinical practice guidelines for asthma and tuberculosis and sits on the expert committee for biologics in severe asthma.
Let's welcome all of them. Please give a round of applause. Thank you.
Good afternoon, ladies and gentlemen. Thank you, AstraZeneca, for inviting me to present two cases that I've been managing throughout this period of time, whereby battery is currently available, and we have sort of like an opportunity to try it on our patient, and these are real cases that I've been managing. So the first case, I would like to present Mr. Chong. He's a 79-year-old man. He works as, previously as a security guard, and he smoked 40-pack years, and he stopped smoking for the last 20 years. So he was diagnosed to have a COPD in Hospital Telok Intan that was like follow-up for the last 5 years. And at the same time, he has multiple comorbidities. He had hypertension, dyslipidemia, chronic kidney disease, as well as benign prostatic hyperplasia. So these are the typical patients that we usually see in our clinic. So checking his BMI, he's not overweight, he has a good BMI, 20 kilogram per meter square, but he lives a sedentary lifestyle. Because of his symptoms of breathlessness, he tends to do less of walking as well as exercise. He had one history of exacerbation, admission to the Hospital Telok Intan. That was way back in October last year. At that time, he was presented with shortness of breath, and he also found to have bilateral leg swelling. And during that point of time, the doctor over there diagnosed him to have acute pulmonary edema, and they sort of like attribute it to the uncontrolled hypertension. And however, when they look at the X-ray, it didn't show any features of cardiomegaly. So the patient family decided to move to central of this Malaysia, and following that, he was followed up under the primary care clinic. In December itself, he was admitted to our cardiology ward. Similar presentation, shortness of breath, bilateral leg swelling, and the diagnosis was been told to have heart failure. At the same time, the cardiologist did found out that the patient probably might be having an exacerbation as well. So the patient question to me was, is my heart causing me to be breathless? That's a very, very important question that we would want to find out in this patient. Is it a heart problem? Is it a lung problem? So we go through the medication list. We check the inhaler techniques as well as the adherence. The patient is having a good and reasonable inhaler technique as well, and the adherence. And the medication that he's using for his cardiac medication, he's on beta blockers, calcium channel blockers, as well as a statin. All right, for his COPD medicine, so he's on dry powder inhaler with salmeterol fluticasone, as well as he was put on theophylline. He also was on other important medication for the osteoporosis, as well as for his benign prostatic hyperplasia. And he has a fear of missing his medication. He feared that what is the consequences of missing all these medications? Do I really need to take all these medications? So the first assessment was in February this year. And when I see him, he's still complaining of breathlessness on exertion. And his CAT score is very high, it's 16, and the MMRC score of 2. So I look back his blood results. His blood test which was done during December, whereby he's on a stable state. At the time, the blood eosinophil count was 140. He has pro-BNP of 626. And checking his kidney function, he has sort of like a eGFR of 42 with no proteinuria in the urine. And his albumin level is good. Physical examination, which was found during the stable state, was a bit of like bilateral basal crepitation. There's no bronchi, and there's evidence of pedal edema up to the shin. And there's echocardiogram being done, and it shows that the LV function was good, 67% with grade 1 diastolic dysfunction. There's no regional wall motion abnormalities with the PSP of 34. So there's a big lung function test being done on the February, and it shows that he has severe airflow obstruction with FEV1 of 39%. With a post-bronchodilator, did show a positive bronchodilator response, but again, it's still severe airflow obstruction. So this is a CT scan. I would want you to have a look at the CT scan. And from that scan itself, we have to exclude TB. If you can notice, there's something in the scan, all right? So then there's we examine the sputum. It didn't show any mycobacterium isolated, and the respiratory culture didn't show any positive bacteria to be treated. All right, so what is the most likely finding from the HRCT? Probably just let our moderator to moderate this session.
Right. So the question here is, what is the most likely finding from the HRCT? So bear in mind, there's sputum AFB. There's no mycobacterium detected. Then, yeah, please answer through the Slido. So what is the most likely finding from the HRCT? Do you think this patient has bronchiectasis, panlobular emphysema, normal lung, centrilobular emphysema, or paraseptal emphysema? Right, Prof. Wong, what do you think of the answer?
Yeah, so they are quite observant. They notice some abnormality over the right upper lobe, which suggestive of some bronchiectatic changes as well as calcification. But the other thing is he also has prominent emphysema. So emphysema-wise, you need to have a look at whether it is panlobular, centrilobular, or paraseptal. For this man, what he has is centrilobular emphysema. Yeah. But yes, true enough, all of you detected the patient had some form of bronchiectasis in the lung. Hence, we need to make sure that the patient do not have any mycobacterium infection. Shall we move on?
Right, thank you. Shall we move on? Thank you, Prof.
All right, so the patient, we go back to the treatment plan for the patient. So he's on his cardiac treatment, beta blocker, although he's not on all the pillars. And for his COPD, he's on dry powder inhaler, ICS LABA, and he's also on theophylline and SABA PRN. Okay, he was referred for pulmonary rehabilitation and also vaccination. So now, looking at this Mr. Chong, he's a 79-year-old with limited physical activities. He's currently on CS LABA and highly symptomatic with a recent history of admission for so-called right heart failure as well as exacerbation. And he has high cardiovascular risk with severe airflow obstruction. Yeah, probably Dr. Afida.
Which of the following treatment plan is most likely to improve the patient's outcome? Bearing in mind that blood eosinophil count at one point was 140, bro?
Yes,
Is it?
correct.
Yeah, cells per microliter. All right, which one do you think? A is adding a LAMA to ICS LABA therapy. Next is increase the dose of ICS-LABA to salmeterol fluticasone 50, 500 microgram, adding sacubitril, valsartan, discontinuing theophylline, adding diuretics to patient, or discontinuing bisoprolol.
All right.
I think it's slowing down there. I think. What do you think, Prof? What would you do?
Yeah.
What do you do?
Okay, because all of us are attending this talk, so hence answer A is most important. Adding LAMA to ICS-LABA, and of course the other treatment will be, I'm a bit surprised, increasing the dose of ICS. All right. Again, probably I wouldn't do that. I think looking at the HRCT, it really looks like emphysematous lung, and patient has a severe severe airflow obstruction. Hence, I think on LAMA would be the first choice for this gentleman. Definitely for the heart failure treatment, probably I would like to let Prof. David Sim to have a chat about this. Yeah.
So for this patient, I don't think he has cor pulmonale. We had to understand that in a lot of COPD patient, elderly patient, they got a lot of comorbidity. So heart failure coexisting with heart failure is very common. To have pure cor pulmonale, that means the right heart failure caused by the COPD, is actually not that common, quite rare in what we see. Most of the time when we encounter a heart failure patient in a COPD situation, it's more like they're concomitant heart failure. This patient have all the risk factor to develop heart failure. More likely, this patient, I would say, given the normal ejection fraction and the elevated NT-proBNP, is an elderly patient with heart failure with preserved ejection fraction coexisting with COPD. And the reason why I say that it's less likely to be cor pulmonale, on the echo, the systolic function of the right heart is actually normal. So this lower limb swelling, all this, I think just part of the heart failure preserved ejection fraction, all right? In fact, I am a bit surprised that the cardiologist did not, after the admission for fluid overload, they did not start any SGLT2 like Forxiga for this patient. Adding sacubitril valsartan, which 5 of you voted for, not really that useful. Don't forget, sacubitril valsartan in the setting of HFpEF is a neutral trial, all right? I mean, I know that because I took part in the trial. I was a national leader for Singapore. So we would say that you should consider SGLT2. I would definitely start SGLT2 inhibitor and maybe finerenone. Finerenone, as we know, is a non-steroidal MRA. It is now being approved for HFpEF. Malaysia has just got an indication of HFpEF. I think that's 1 or 2 months ago. That was what I would do to optimize for this patient. And adding a SGLT2 and the finerenone will also help with the lower limb swelling for this gentleman as well, because you cannot literally let the fluid overload, the lower limb swelling just be unaddressed. And of course, by doing all this, I would also consider cutting off or taking off the amlodipine, because we know that calcium channel blocker can contribute to a lower limb swelling as well. Of course, while I do all that, I also expect the respiratory physician to optimize your therapy to a triple therapy as well.
Prof, Dr. Arif, if you don't mind me asking you about the choice of discontinuing theophylline there, what do you think that someone did actually choose that? Is that something that you would consider doing?
I will certainly discontinue the theophylline, okay, because you know that it is very weak bronchodilator. So that will be your last choice if you want to start a COPD on theophylline. I think we need to maximize the inhaler, right? So I agree with Prof. David that we need to optimize the HFpEF first with your MRAs and your SGLT2, and then from the lung point of view, I think the patient should be started on triple therapy. So when choosing a triple therapy in this patient, I think single device triple therapy will benefit more in this patient with the use of aero chamber.
What do you, can you comment on our primary care kind of limitations that we got? You know, theophylline is something that is readily available for them. having triple therapy is going to be a bit tricky, what would you advise them to do if, let's say, you come across patients like this and they're stuck in terms of the patients having persistent symptoms? What would you say?
So I mean, just at the point of view of primary care physician, when you look at patient is already what they call it, group E, so the patient should be referred to, it's very justifiable for you to refer this patient to a respiratory physician or a specialist clinic where most of this drug is available.
I guess
So don't try to manage everything until the patient become breathless and sent to emergency department. You know that the patient have recurrent exacerbation, and then you just refer to a specialist clinic. All right.
I guess there is always that concern about not wanting to put pressure to the tertiary hospitals, the specialist clinic, but bearing in mind that it does actually make a difference in terms of the patient's outcome. Okay. Yes, Prof. Wong?
Okay, I shall move on. So, all right. So based on the assessment, we think that adding on a LAMA on top of the ICS LABA will be more beneficial for this patient. Hence, for the treatment plan, I started him on single inhaler triple therapy. The choice would be BGF for this gentleman, as he has high cardiopulmonary risk. And I discontinued the theophylline because I felt that the patient may develop cardiotoxicity if ever he's using the theophylline, and theophylline is just a weak bronchodilator, as what mentioned by Dr. Arif just now. So this was the treatment that he was given. So you can see before and after the therapy, there's much reduction in his symptoms, particularly on the shortness of breath, and surprisingly, his pedal edema actually is resolved. And his exacerbation for the last 3 months was new, and with a good CAT score, his CAT score has half to 8, and with the MMRC score of 1. You can actually look at the lung function test, but it actually did not improve much. But the main thing is the patient has improvement in his symptoms, respiratory symptoms, as well as his pedal edema. So what I can conclude is that this case is actually a symptomatic COPD despite of ICS LABA, and he actually has a lot of COPD-related dynamic hyperinflation. And the other thing is he has a heart failure with a preserved ejection fraction. Or probably during the echocardiogram, we were unable to capture any early right heart failure features. But again, I totally agree with Prof. David that this is likelihood to be heart failure with preserved ejection fraction. And certainly, he actually improved a lot with the BGF treatment. His CAT score, MMRC score, lung function has improved, as well as we have prevented further exacerbation in this gentleman. Although it's still very early to say, but 3 months with a better quality of life, I'm sure this patient is the happy patient. All right, is there any other comment for case number 1?
Maybe I'll just add something that clinical pharmacist perspective, I do agree about the amlodipine, and I think usually the simvastatin dose also is quite high, it's 40 milligram. The MHRA recommendation, when you have amlodipine on board, you should cut down your simvastatin to 20. I think just the clinical pharmacy side is screaming out a bit. But I think I do agree that we should off the theophylline. The toxicity profile probably not so suitable for this APO and heart failure patient.
Just one comment. The theophylline in respiratory context is like the digoxin in our cardiology context. We hate this kind of drug because it's a very narrow therapeutic range, and you need monitoring a level, all that. So just because digoxin is easily available in the primary setting doesn't mean it's the right thing to do. So in Singapore, we have moved away from drugs like digoxin, theophylline. So what we do is we make sure that newer generation of drug that's an impact on mortality and mobility is also made available in the primary care setting.
Can I ask Jaya, what do you think of Pyroxan, Dr. Jaya, in terms of change?
I don't know whether we can discuss it here. Well, there's all definitely role, but I think before going there, there's a lot of things to discuss about this case. The bronchiectasis part, we have really addressed it. I want to do a BSI, severity index, look at the FACET score and whether anything growing, Pseudomonas and things. The bronchiectasis part, why I'm talking about it, because we're giving triple therapy, there is an inhaled corticosteroid there, and of course, it's allowed to use in COPD, but when you still have overlapping with bronchiectasis, but we have to still monitor that part. We have not talked about airway clearance. There's a lot of things to talk about, and I'm not sure whether we should discuss more on, but I think there is a role. All right?
Yes, okay, there's a rule. Yes or no?
I see the table there, they may not like it, you know.
So I guess this case, the most important take-home message is we have to treat the patient's symptoms. And of course, ICS/LABA in COPD wouldn't be a recommended treatment nowadays, and we should at least put the patient on LAMA as one of the backbone therapy instead of just putting the patient on ICS/LABA. And the second thing, we have to make sure we assess the cardiopulmonary risk and, of course, to address any potential risks and also optimize the cardiac treatment. Yep. Okay, I would like to move on to case number 2. This Mr. Eddie, he's 65 years old. He's a lorry driver. He has been following up under our care for a number of years. So he's been smoking 44 pack years. That's the reason why he was not being optimized so much because of the smoking history. You know, when we see a patient who actually smokes, the first thing we'll talk about, you stop smoking, please. Stop smoking, then only I optimize your treatment. So, but I felt like we have to move away from that. Then we have to actually be more aggressive in this kind of patient, because this kind of patient are the one who's going to keep on coming in for exacerbation. So he's been diagnosed with COPD since September 2023, whereby the first diagnosis was when he admitted for acute exacerbation. He's been smoking for 44 pack years, and he was still smoking during that period of time. The other comorbidity he had was BPH as well as retrosternal goiter, which doesn't cause much of a comprehensive symptoms. He's rather underweight with a BMI of 18.4. Again, all our COPD patients lead a sedentary lifestyle because of the symptoms that they had. So moving on, looking at the exacerbation history, he had multiple exacerbations. So the first exacerbation was whereby he was being diagnosed. That was way back in 2023 with secondary to upper respiratory tract infection. And he had another exacerbation about 2 years later, and with another bouts of URTI. And the recent exacerbation will be December last year. And that time, the sputum culture grew Klebsiella pneumonia, but the X-ray did not show any evidence of consolidation. And he had another exacerbation this year, February. So his question to me is, why am I keep getting admitted to the hospital? Can I just stop this? Right, so I've been admitted each time for exacerbation. I'm very, very tired. And again, I feel more breathless each time when being discharged from the ward. So during the assessment, what I noticed that he has persistent productive cough, and also he has frequent exacerbation. I think the productive cough is a sign or the symptoms that showing that the patient has chronic bronchitis features, right? And of course, the CAT score was high, 11, with an MMRC score of 2, and the blood test showed that he has a high blood eosinophil count of 550 cell per microliter. Examination of the patient showed there's occasional bronchi with prolonged expiratory phase. And the imaging-wise, on that on the February admission, it didn't show any consolidation. But there's a retrospective HRCT being done, and it shows minimal emphysematous changes with no bronchiectasis, and there's a right thyroid goiter with retrosternal extension. So we assess his lung function, and the post-bronchodilator FEV1 shows a severe airflow obstruction of a 38% predicted. So this is an X-ray in February. That time it was just hyperinflation without any consolidation, and the HRCT just shows minimal so-called emphysematous changes. So okay, I collected all his follow-up and look at what are the medication that he's been on. So since September 2023, he was only on LAMA. And only 2024, a year later, he was given LAMA-LABA. All right? And then he has symptoms-wise still having persistent cough, and then his lung function still very low, and in fact dropped from 40% to 33% a year later. All right? And we look at again, in 2025, he was on LAMA-LABA, but unfortunately, his symptoms never improved. So he has a persistent cough with high MMRC and also CAT score. And his lung function, again, still very severely affected. Until one time, he was exacerbated on the second exacerbation. The blood eosinophil count was being checked and it was shown to be high. All right, and then he was switched to a dry powder inhaler, LAMA-LABA. And again, another third admission with a high blood eosinophil count. And that time, the sputum culture grew Klebsiella pneumonia. And he was maintained on SMI olodaterol tiotropium. So the last admission was February 26. So you can see like the blood eosinophil count is strikingly showing that the patient has high blood eosinophil count, but these are during exacerbation period of time. So we couldn't actually have a blood eosinophil count during the stable state because he kept on admitting for an exacerbation. And the other thing the doctor was very concerned about is he had infection, and hence the ICS was not initiated. And also the patient was still smoking during that period of time. So this patient, 65-year-old, frequent exacerbation history, the first until the fourth exacerbation, all secondary to some form of infection. And yeah, maybe I just pass it to Dr. Teo.
Yeah. So questions to the floor as well, please answer in Slido. So in your opinion, what is the highest contributing factor to the COPD? So bear in mind, and one thing is very interesting is the baseline eosinophil count actually from 30 to recent, since 2023 until recently is 470, ranging from 470 to 550 cells per microliter. So what do you think the highest contributing factor to the patient with frequent COPD exacerbations? Is it due to smoking, or is it due to the non-optimized treatment, or incorrect inhalation technique, stress, or change in weather by the end of the year? Everyone like to do that, right? Whenever we come to the hospital or whenever the patients presented to the hospital, they will say that either they are stressed or because of the cold air, exposure to the cold air. They like to do that.
I see still a lot of us still attribute the exacerbation due to the smoking. I totally agree. Smoking is something that we need to address from the start. Yeah. And of course, about 1/3 of you actually felt that unoptimized treatment and has to be optimized, particularly maybe adding on ICS for this gentleman. And I guess the patient is very well versed with the inhaler technique, but again, it is important to make sure the patient know how to use the inhaler because the patient was switched from SMI to dry powder. And certainly there must be some error in the inhalation technique. Okay. And the rest are quite of a minor trigger for the patient. Yeah. Maybe I would like to ask the panelists for their opinion.
Dr. Arif, what do you think of this? It's very, very difficult.
Yeah, this is a typical kind of causes for exacerbation. I think exacerbations are multifactorial. We cannot just blame everything on cigarette, okay? So unoptimized treatment, inhalation techniques, especially incorrect inhalation technique, something that people have been has been underdiagnosed, okay? Patient keep on been giving a lot of medication, these high-end expensive medications without the doctors or healthcare providers assessing the techniques. So I've seen a lot of patients with COPD and even asthmatic patients. I think at least 70% of them, have a problem using their inhalers. Okay, even this highly educated patient who you have been teaching them to use a proper aero chamber, also they made a mistake. So you really need to emphasize on an inhalation technique.
I think one that can help is whenever the patients come to see you, ask them to bring the medication and their spacer as well, just for you to reassess. Sometimes we assume that because they've already been taking the medication for a while, they would have already been an expert, but you'll be surprised that all this while they might have used it differently. Prof. Martha is still on the line. Just don't forget her. I do actually want to ask Prof. Martha about the situation in your country. I have to say that in Malaysia, I think some of us would have some reservations in giving triple therapy for active smokers because they are not cheap medication, and we want to reserve it sometimes probably for patients who are, well, a bit more deserving, people who have already taken an effort to stop smoking. What about in your country, Prof? Is that something like something that is happening as well, that there is reservation in giving triple therapy among smokers?
Thank you. This is a great question. So in Spain, I think our healthcare system differs a bit from Malaysia because our healthcare system is a national security system. So I would say that medicines are very cheap, and primary care doctors as well as us can prescribe triple therapy without any burden. So in Spain, despite the patient being a current smoker, we can prescribe, and we do prescribe triple therapy. But we encourage very deeply our patients to stop smoking. But I think you would all agree with me that there's like this small percentage of patients that cannot stop smoking despite anything you do. And this is a big, big problem, because if we move towards biologics, for example, we do not prescribe biologics if the patient is an active smoker. But we don't have that problem with triple therapy.
Thank you for that, Prof. I guess another point to make is that sometimes we advise our patients to stop smoking, but it's not something easy. So worthwhile looking at, the things that we can offer them, like, what do you call that? Replacement therapy, nicotine replacement therapy to be offered.
Yeah, maybe Dr. Jaya, you can enlighten us on the smoking cessation clinic. Is it successful in Northern?
Yeah. I like to do this, but what happened, they have moved the service to KK. So we are now referring to Klinik Kesihatan. Unfortunately, this is very unfortunate because many do not go. It used to be very successful when we were doing it in Hospital Pulau Pinang. Since the service was, started being outsourced, that I noticing that many do not go. I think probably the most cost-effective intervention is smoking cessation, and also shown to have mortality benefit. You don't really need to spend a lot of money, like 50,000 for biologics and things like that. This should be done aggressively, but I used to enjoy doing this, but now my hands are tied. So I focus more on inhalers. But inhalers, I just want to remind something that what we do in Penang Hospital, part of our bundled care discharge process, especially those patients who are having frequent COPD exacerbation, they are coming in every time, right? So what we do, we know that exacerbation can drop your peak inspiratory flow. It drops during the first day of exacerbation, then it recovers towards the discharge. So you have a drop, you recover. If you have multiple exacerbations, right, then it will drop, it will recover, it will drop, recover. Finally, the net effect of peak inspiratory flow may be reduced. So maybe you have started a dry powder 10 years back and patient have good inspiratory effort, but after series of exacerbation, they may not have that sufficient inspiratory effort to activate dry powder inhaler. So part of our bundle care process, discharge process in HPP, every admission at discharge assess the peak inspiratory effort so we can prescribe the appropriate drug. Not saying dry powders are bad, but you know not every single patient can use every single device. But if you give a PMDI, elderly patients, COPD with a lot of comorbidities, you have to think about a spacer because coordination issue. So these are the things that we focus a lot that I teach my clinical pharmacists.
So can I have a question for Prof. Martha? Hi, Prof. Arif here. Sorry. Talking about smoking cessation clinic. So what kind of a smoking cessation program that you have in Spain, and do you have some sort of like a tobacco harm reduction product that you use for cessation clinic? Thank you.
Thanks for the question. In Spain, in each hospital, we have a special clinic for smoking cessation. So there is a respiratory specialist that focuses just on smoking cessation. And then we have a big help with primary care. I think the biggest percentage of smoking cessation programs are managed by primary care physicians, which is a big help. So for this, we have different therapies, and recently they have all been financed by our healthcare system. So it is cheap for our patients to take a going smoking cessation. We use nicotine patches, we use gums, we use nicotine sweets, and then we use some antidepressants. We use bupropion, we use Champix, we call it, and we use this new drug that is called Citizen. I don't know if you have it in Malaysia. So we have many different interventional therapies, and then we do a very thorough follow-up with the patients. We see them every week and ask them about symptoms, adherence, etc., etc. I think globally in Spain, I would say the positive impact of these programs is that they're very successful.
All right. Probably for the southern side, like Singapore, do you have any successful smoking cessation program?
Yeah, so we had the same problem for cardiology. So smoking is also an issue for us as well. And to make things worse, our patient like high salt diet and refuse to comply to fluid restriction as well. So we do have smoking cessation clinic, not just run by respiratory side, but also by the cardiology side. And just like in Spain, we have the, all this nicotine patch, Champix, all this drug that we use as well. Obviously, it's helpful. Then back to the question, is it fair to give triple therapy in somebody still actively smoking? In Singapore, I think if a patient is still actively smoking, refuse a fluid restriction and high salt diet, there will always be this group of patient. We will not hold off our cardiac drug like SGLT2 and the usual drug. We will still give it to them because we know it still works in this group of patient. Maybe not as ideal, but still it has some benefit because of preventing, even we cannot totally prevent the readmission, but just reducing the episode, that will save the nation a lot of money, all that, you see. But of course, if you talk about biologic for this group of patient, for respiratory context, for us cardiology, we're going expensive devices, heart transplant, that we will probably say no to the smoker. But for generally for the inhaled drug or the oral drug, we'll say yes. But expensive biologic and devices, because of the burden on the healthcare system, I think in the southern part, even the rich nation like Singapore, the taxpayer will not accept that.
How about the other panelists? Will you do the same? Starting the patient on the triple, you're putting away the smoking issue, and then would you actually upfront start the patient on triple for this time round of exacerbation?
I will start the patient on triple therapy. I mean, I just echo what Prof said just now. It's unfair for you to withhold treatment just because the patient is a smoker. So he will certainly benefit from triple therapy. I have a patient, he came for exhibition. So when you open up his drawer, there's a cigarette here and and the inhaler there. So what can you do? They are adult, so they can make the decision by themselves.
I guess you should put the other box, which is the nicotine replacement therapy, lah. The patches or something.
Yes.
Okay, that was a good
I just
discussion.
want to share. I just want to share a recent case from my center. So I have a patient here, very stubborn smoker. So he actually confronted me when I refused to upgrade his medication to triple therapy. So he put it this way: if I do not feel better, right, how can I have the motivation to quit smoking? So because of that, yeah. So because of that, then we have men's talk. Yeah. So yeah. Then he actually promised me to quit smoking, and I provided him with triple therapy. So he successfully quitted smoking. So yeah, that's one of the rare cases.
Echoing that, not to spoil the fun, I had a patient, active smoker, started triple therapy, then he increased the number of cigarettes because he felt better, you know. He felt better, then he increased the smoking number of pack years, but he got married, another one.
So
so the triple therapy also brought him another wife.
Yeah, I would say this is like, I don't know whether it can be all good or it can be all bad. I'm not so sure.
But I think data, if you look at data per se, the science, what the science saying, if you have ICS, your response towards ICS is actually reduced when you are active. You are active smoker, but it's not like no response. Got response, but reduced compared with the active smoker. But treatment like long-term macrolide, you should not give it to the active smoker because study showed the confidence interval is not significant, so you should not give. Biologic, okay, let's say IL-13. There's Notus boreas, they do have smokers in the sub-analysis, and they did show that, smokers, current smokers, they did okay, but not as good as who have quit smoking. So I think we have to still look at the data very clearly.
Okay, that was a very good discussion. If we talk about smoking, it will be forever, 2-3 days, 2-3 weeks also. We are not going to get enough of talking about smoking cessation. Well, what do you think? Did the patient stop smoking? Did I convince him to stop smoking? Let's go back to our case. Yeah, I mean, he's a frequent exacerbator. He has chronic bronchitis symptoms, currently on LAMA-LABA with high blood eosinophil count. He has severe airflow obstruction. So I put him on triple therapy, all right, BGF, because I think I need to make the move. If not forever, this patient will keep on coming in. 4 exacerbation already. I think this is enough for this patient. I just start him on BGF. And pulmonary rehabilitation and vaccination, of course, I really have the man-to-man talk with him, ask him to stop smoking. He did manage to stop the smoking, right? Okay. So what happened is the cough become minimal. So his chronic bronchitis symptoms all go away, right? So, and then he doesn't have any exacerbation. And his CAT score actually dropped from 11 to 6. And his MMRC also improved, right? The lung function did not improve much because the patient has persistent airflow obstruction. But again, the more important is the chronic bronchitis symptoms seems to go away. And again, he actually stopped smoking since February. That is a good sign for him. And what I can conclude, this is a case of symptomatic COPD, despite of LAMA-LABA with features of chronic bronchitis, frequent exacerbator, and high T2 inflammation. So he responded to the triple therapy, and this has been shown by the CAT score, MMRC score, as well as prevented another exacerbation for him. Although it's still very early, 4 months, but I believe that this patient will improve further. So now the patient is stable with current treatment plan. What's next? Are you going to do something else, like probably we go to the Slido questions? Yeah.
So sorry, Prof, we're running out of time. There's only half a minute left. Yeah. So probably we can go through it. Just your opinion, Prof, you don't mind?
Oh, well, I would say, of course, keep the patient on the triple therapy. I wouldn't want to de-escalate the treatment. The patient has gone so far and then he's improved so much. With the triple therapy, I'm sure we should carry on with the treatment.
What do you think about the options of remove ICS? Someone did actually choose that. Anyone in the panel, please? Your opinion?
Certainly, I will not remove the ICS like what Prof. Wong mentioned just now. His, what do you call this, I mean, like bronchitis symptoms has gone away. I think that is the effect of the ICS, which he benefited from.
Can I check, as a cardiologist for the respiratory physician, to educate me, in what situation then will you consider removing the steroid part? Yeah, but for us in same heart failure, we don't remove our medicine, but in certain situations where they get a persistent hypotension, we have no choice.
I think the most important is like the patient might have a mycobacterial infection or a recurrent sort of like a pneumonia, then maybe we have to decide to remove the ICS. And definitely the blood eosinophil count is very important. We also look at that as well.
Prof. Martha, any opinion from your end?
Totally agree with what my colleague said. If patient has to be admitted or treated for pneumonia recurrently, or if bronchiectasis, if this patient had bronchiectasis, started giving him problems with mycobacteria or chronic bronchial infection.
Yeah. All right, I think that will be it for the session today. Thank you very much, everyone.
Thank you so much.
Thank you to all our panelists for the insightful discussion, especially to Prof. Martha all the way from Spain and also Prof. David from Singapore. Next, I would like to invite our moderator, Dr. Nadira Azmi, together with our panelists, Dr. Mat Zuki, Dr. Ileana, Dr. Arvindran, for the session, Malaysia's Lung Health Initiative in Action, Transforming Respiratory Care. So Dr. Nadira is AstraZeneca Malaysia Respiratory and Immunology Therapeutic Area Medical Lead.
It's my pleasure to introduce to you Dr. Matzuki Matjaib. Dr. Matzuki is the current National Head of Respiratory Services. He completed a fellowship in Interventional Pulmonology in Marseille, France, and contributes to national training and drug committees for respiratory medicine. He is actively involved in international and local studies as principal investigator. His research focuses on severe asthma, tuberculosis, especially MDR and XDR TB, non-tuberculous mycobacteria, COPD, TB, and diabetes mellitus.
As for Dr. Ileana Binti Ahmad, she is a public health specialist who leads Malaysia's national NCD surveillance and cancer prevention portfolios. She has been supporting policy development, program implementation, and service improvement for NCDs. Her academic and conference contributions include work on NCD system strengthening, diabetes outcome, and COVID-19. She brings a broad public health perspective to respiratory care, focusing on surveillance, prevention, and integrated services to improve population health.
For Dr. Arvindran Alaga, a respiratory physician with fellowship in interventional pulmonology in Japan and respiratory medicine Malaysia, and professional recognition including FRCP Edinburgh, FAPSR, and CMIA. He leads hospital and state respiratory services, is an active researcher and educator involved in undergraduate and postgraduate training, and serves on the editorial board of Respiratory Endoscopy, an official journal of the Japanese Society of Respiratory Endoscopy. He contributes to the academic community as a journal reviewer and to the medical profession nationally as honorary deputy secretary of the Malaysian Medical Association.
Please join us in welcoming them to the stage. And Dr. Nadira, the floor is yours.
Thank you so much, Dr. Teo and Dr. Afida, for the kind introduction. Hello, everyone, and thank you so much for coming, spending your weekend for this BREEZE Summit 2026. So my name is Nadira. I'm the Medical Therapy Area Lead for Respiratory and Immunology in AstraZeneca Malaysia. So I have with me today these three esteemed panelists. For our session for now is the Malaysia's Lung Health Initiative in Action to Transform Respiratory Care. So probably I'll first start off this session by asking Dr. Ileana the first question, right? So exactly, I think a lot of you here also, some of you probably have heard of what is Lung Health Initiative before, but probably some of you have not heard about it, and how has it come about? What was the idea behind initiating this lung health initiative, and especially from the MOH policy side, policy-wise, why was it implemented, or why was the idea first to start off this lung health initiative? So probably Dr. Liana, I give the floor to you.
Right, thank you, Dr. Nadira. Well, yes, I think at this point, many of us already aware of a lung health initiative. I hope so. And this has been, it's coming into the second year of this initiative from since its first inception in terms of idea. So first, we talk mainly on lung cancer. So if you look at in our country, lung cancer is diagnosed as 90 to 95% at stage 3 and 4. So we do not have anything on lung cancer screening in our country. Okay, so the discussion was around lung cancer at that moment. And then we thought that, and then we go into the main risk factors for lung cancer, which is smoking. I think it was talked about very much in the previous panel session. So smoking is one of the main risk factor that we were looking at that moment. So, but if you look at smoking as a risk factor, it does not only cause lung cancer, but it has its effects is on the lung itself, on the whole lung itself. So if you want to take this up with only lung cancer, so it's very much specific to only one disease. So we look at the other risk factors that also can cause other lung diseases other than lung cancer. And we look at also the other burden of lung diseases in our country. So not only lung cancer, so I come from non-communicable disease area. So, but we also know that tuberculosis is also a major issue in our country. We have asthma, we have COPD, and we have other lung diseases as well. So then it comes that, and when we look at the risk factor, we look at also, there is a contribution from occupational setting. What do you expose at your workplace? And we also look at the environment, very much has so much of effect or impact on your lung. So from there, we discussed, we look at the burden of disease especially. I will review all the programs that we have and also policy that we have in our country in terms of lung disease, which not many, and we did not have any actually for chronic respiratory diseases and comes lung cancer, but we do have a very strong program on tuberculosis. So and also, but we also think of how are we going to move forward. You know, it's not something, an idea that comes from the ministry, so you come up with a policy and you ask all the people on the ground to just, you know, run this program. So we want more than that. And how are we going to do that is we get our health minister to get to know that this issue that has been there for quite some time, and our minister has, and we were lucky that our minister has this support on us, and we also make a move on getting a lung health resolution to be tabled at the World Health Assembly, so that it's not only at the national level, but we want to get the support from global. Because if you know, even at the global level, we do not have any strong on chronic respiratory disease and lung cancer as well. So, but there is on infectious part of the lung disease. So therefore, we within a year, we are able to table a resolution. I might spare all the, you know, hard work and tears and sweats to reach to the resolution within a year. And from the resolution, so now we not only have the global commitment, but we also prepare ourselves in terms of implementation at local level. And that would be not only looking at the disease itself, but we move a bit further away from the disease, right, from the risk factors. So there are many things that we are doing now in terms of the risk factors, prevention of the disease, screening and integrated approach of the lung health management and screening in the primary care. That will be the G's of this initiative. Strengthening the primary care for universal health coverage, and also and through whole of society approach.
Thank you so much, Dr. Eliana, for that very comprehensive answer. And I guess the key word is really integrated, because lung health, again, is not just lung cancer. There's also COPD, asthma, TB, and lots more. So probably I can ask Dr. Mat, right, this question. Now we get the whole idea of why Lung Health Initiative was first started, but how is it any different than what is being practiced clinically now, before lung health and after lung health? And on the ground right now, from the beginning when it was first started until now, what has happened?
Thank you, Dr. Nadira, and thank you for Isaac for having this special session, I call it. It's very short, but this is an opportunity for at least 3 of us as a technical working group within the Lung Health Initiative TWG to share with all of you on what is LHI all about. Because I think when we talk about disease, conference, causes, it's always very specific. Disease, asthma, COPD, ischemic heart disease, coronary artery disease, all individual basis. Approach is on disease base, not even a patient's base. If you're talking about cardiorespiratory disease, it's something new, probably new. That is one of the potential approach that we probably should look into. So because of that, we are seeing many respiratory diseases being managed as a disease itself, not per patient. Even one patient with multiple disease, but being managed and approached according to the disease, how is it being diagnosed, how is it being treated. So it's on individual disease, not on the patients, and even not on risk factors. So that's why Lung Health Initiative looking at more at a broader aspect of approach to a patient who might be sharing the same risk factors, having the multiple disease. So approach that includes from preventive aspect, from promotional aspect, early diagnosis, this is one of the priority, screening of a patient. That's why I put out a question on when we screen disease for early stage of the disease, what can we offer a patient in terms of treatment, especially COPD, if you diagnose them early, what can you offer? Is there any treatment? For cancer, if you treat them, if you diagnose them early, is there any options, intervention that actually change the scenario? Because we always say in our respiratory disease, it causes death. And one of the reasons why primary disease is one of the major cause of death is because of late diagnosis. So why they're being diagnosed late? Because of our practice. In a way, we tend to diagnose them when they get symptoms. They come with symptomatic, they get admitted, then they get diagnosed. By the time they're being diagnosed to be having respiratory disease, it's already late stage of COPD, late stage of asthma, severe asthma, late stage of lung cancer, and so on. So this is a traditional approach leading to late diagnosis, mortality, increased hospitalization, increased cost, and we are talking about advanced treatment of respiratory disease. But what happened down there in primary care was a patient be able to be diagnosed early as possible, talking about COPD. We are not there yet because COPD diagnosis requires spirometry. How many of GPs, private, even in KK, within Ministry of Health, not even 30% is equipped with spirometer. We are talking about advanced disease, advanced treatment, but diagnosis is not there yet. So some patient might be diagnosed wrongly and being prescribed medication wrongly. So in total, in summary, the Lung Health Initiative basically looking at the various aspects of lung health, not only disease, but lung health from the primary prevention, primordial prevention, promotion, early diagnosis of asthma, COPD, lung cancer, and tuberculosis, and of course early treatment, and treatment optimization within the reachable by primary care, as well as rehabilitation. And of course, along that, we have a digital transformation in terms of collecting data. Of course, we are actually looking at the outcome of patient from this program. So basically, it's not only within MOH. This is what I'm just to conclude the question. So it's integrated approach, not a disease-based by itself. It's actually it cut across multiple diseases. Basically, at the moment, we are targeting for 4 diseases: asthma, COPD, lung cancer, and tuberculosis, because they share some of the risk factors. And we can actually approach them within a primary care and with a referral system to tertiary or secondary care. So it's integrated approach within the service, within MOH, as well as outside MOH, in the private as well. Of course, this is the first stage at the moment, 1 year after the LAHI being launched by YBMK 1 year ago. So we basically passed 1 year now, and with the initial stage of 7 health clinics running this program with integrated lung health screening at the primary care setting, from the patient going to the screening program, with the risk factors being identified by questionnaires. And we identify risk factors, is patient having risk factor for asthma, risk factors for COPD, for example. So they will undergo the process of screening with questionnaires as well as parametry. So with that, we hope to catch them early and treat them early. If patients having risk factors for lung cancers, for example, smoking history, significant smoking history, as well as family history, then we actually proceed with chest X-ray with AI integrated or AI assisted X-ray. Following that, there will be some needs for low dose CT scan to catch any early nodule in the lung. So with that nodule, then patient will be referred to appropriate specialties for diagnosis or for surgical option as well. So this is a package of patient presenting to primary care, doing screening, having early diagnosis, having treatment, accessibility is there in primary care, and we hope to treat them early so that they don't have to be on triple therapy. Sorry for saying that. No, I'm talking about catching the disease early rather than catch them late. And with that treatment, it costs more costly to treat patient at advanced stage compared to early stage. So at the moment, 7 clinics is running. So this year, we are actually expanding to another, at least hopefully another 150 health clinics within the Ministry of Health. So hopefully we can actually expand to the private setting as well. That includes GPs. I think it's quite a number of GPs present here. So the program is not only within MOH, it's going to expand throughout the country, but in staggered way, years to years, and we hope to see the progress and the outcome within these few years. Thank you.
Thank you so much, Dr. Ahmad. And I think that's a problem that we see not just in lung health, but also in the other disease areas as well, where there is no connection between the primary and tertiary care and catching the patients early. And also, we really do need that. And this LHI probably is a good start for lung health. And yes, and now talking about what's really happening on the ground, for Dr. Arvin, right? So in Kedah, I believe that Dr. Arvin has some best practice that in Kedah that lung health in a way was already started even before LHI was even implemented. So Dr. Arvin, do you want to share your experience and how did that improve in your patient care?
Okay, thank you very much, Dr. Nadira and AZ. So I think I need to go back to past medical history first, actually, if you ask me. So when I came back from Japan, I think, fortunate or unfortunate, I was the only respiratory physician in Alostar. So what I'm trying to say is, I started seeing a lot of backlogs, a lot of delay in seeing the patients, and bed being occupied with the chronic diseases, especially with the severe asthma and complicated cases due to TB per se and everything. So 2020, when I came back from Japan, it was midst of COVID, but upon recovering from the COVID, what we noticed is TB, severe asthma, severe COPD, lung cancer became a major issue for us. So what we did at initial stages, I think Dr. Ileana was there with us during JK in Kedah time. We started issue a circular to all the clinic kesihatan, say that they don't need to ask my appointment. Any suspected TB cases will be straight away seen in our clinic within a week. If need a bronchoscope within the next available slot, we do the bronchoscope to get a sample or whatever. So we did for almost 1 year, and we had a very good 200 plus cases. What we noticed is those who are suspected TB or presumed to be treated with empirical TB, 42% of that actually ended up as having lung cancer. So this changed the entire practice of we are treating as a TB. So in Alostai, especially cluster Utara per se, there is no empirical TB treatment unless patient intubated or suspected pericarditis, TB pericarditis or TB meningitis. The rest of it, we try to intervene as soon as possible. And by that, we already started tackling the suspected lung cancer and suspected TB per se. So moving that from 2023 onwards, my attention changed towards severe asthma. So if you notice, respiratory diseases are second most common cause of deaths. And 66% of asthmatic, I think as Dr. Mat mentioned clearly, we don't even have a spirometry in clinic kesihatan. And our particular healthcare system, a patient can go to clinic kesihatan today, next day he can go to a district hospital, the third time he can go to a private GP or private medical center, and finally ended up in tertiary center, with none of this actually equipped with the electronic medical record. And this patient can be on a loop, given a salbutamol inhaler, prednisolone, multiple times. So we try to weed out the whole issues. First of all, we had a meeting with all the stakeholders. So what we had is our primary care physicians and also some of the GPs and also FMSs and also, MMA being part of it as well. Actually, we try to analyze this cost. This is already published, whether we can bring down the cost or not. That's most important actually. And we started with the first our kickoff meeting with all the, Dr. Sriwayu was there. Actually, there's a lucky charm for us actually from a primary care point of view. We gather all the primary care physician from the district hospital. That is a network involved in our entire severe asthma network. And we try to utilize a digitalized form, QR form. No need to send me a detailed referral letter. So you just scan a QR code, you tick all the necessary boxes, the referral will come to me directly, and I give the next available appointment. So this is how the whole thing sort of flow will go on. If you notice, difficult to treat patients, family medicine specialists and physician in a district hospital will take care of it, and they refer the case, and we will follow up. So do we have a data to support whether our initiative really went on well or not? Yes, we have published our data, if you notice. Those who are interested can download this particular journal. But what I would like to highlight is, we try to achieve, although KPI is 2 weeks, we try to give all the appointment within 7 days. And the fastest we have diagnosed a severe asthma is within 30 days, actually. And out of 53 patients, 5 patients is just fall nicely within the data, actually. 5 patients eventually diagnosed as severe asthma, and 14 of them, actually, we escalate the treatment. And what we notice is the ACT score gone up 21, which is poorly controlled ACT score, and after that, we managed to get the ACT score 21 above. And all this also come up with the very good cost effectiveness. We have published another paper as well. By initiating biologics with the appropriate population, we should be able to save almost 114,000 Malaysian ringgit per patient per year by reducing the hospital visit, by reducing the ED visit, by reducing the unnecessary nebulizer and everything. So overall, by try to create the whole network within the Kedah and Kota Star, we managed to bring the care nearer to patient with lesser cost actually.
Thank you so much, Dr. Arvin, and that's a very good initiative, and I really think that the patients in Kedah also, especially those severe asthma that were able to initiate biologics early on before their disease progression became even worse. I think they are very thankful for having this network for them to be able to initiate treatment very early on. So we have a few more minutes left. Probably I would like to ask each of the panelists, right, what is your future aspirations and your hopes for lung health moving forward from now until, and we have a huge audience here today that consists of tertiary, secondary, and also primary care. So probably I'll start with Dr. Eliana first. Your hopes for LHI among all these healthcare professionals here.
All right. we also, when we develop this, we also learn from the previous programs that we have in our ministry. You know, most of the time we don't talk to each other. You know, everything is in silo. Whatever that you do in primary care, it ends in primary care, and then we don't know where the patient goes. And then comes all these case studies that you see in the hospitals. So we do not want that. So when we develop it, we put in mind what we want at the end from in terms of navigation, from the very moment the patient has the risk factors and until the end of if he requires treatment or rehabilitation. So, and we also do not want it only to be in our primary care clinics. Of course, it's the main place for people to go. It caters most of our communities, but we want it also to be in throughout our healthcare systems in terms of screening, diagnosis, treatment, and data collection especially. Data is very important. I know some feels that is an additional to your work, but data is one thing that, one of the reasons why we want asthma, COPD to be on board as well, because we do not have anything to support. When you don't have any data, how can you suggest for a policy to be built and how are we going to plan for the country? So that is also one thing that I'm looking forward to, and with our own system that we hope that it can talk between primary and tertiary care, and we know what happened to that patient, so it can help us in terms of planning for the next, after 2030 planning. And also, one of the main components within this initiative is a whole of society approach. So we do not want only the work is within the ministry, but we open to all the other people outside, especially our strategic partners. We have a very strategic partners for lung health that includes AstraZeneca, and we want this public-private partnership to be going on and to benefit not only us, but not only the treatment or not only the diagnosis part, but the whole component if you look at the roadmap of Lung Health Initiative. So we have a plan until 2030. We hope that the expansion is going on as per plan by next year. And with the support of the technology, with the data, so that we can plan ahead better with more lung diseases that can be included structurally within this initiative.
Thank you so much. And Datuk Mat, what about your hopes for LHI?
As names implies, initiative is action-based effort. It's not just on paper, it's not just policy. It's about doing things to change the current challenges, the gaps that we are having for centuries, for decades. We keep on saying the same thing. So this is, to me, this is a game changer, and this is a transformation of what we are having in terms of respiratory disease or lung health, to have something on implementation. As I said, it's action-based. But we need all of you to be part of it, not just government, not just in hospital, it's also in primary care setting that includes private clinics, to participate in this project in order to achieve the success and the objective that we are actually looking for the next 5 years at least, downstage or downgrade patient with lung cancer from primarily majority, more than 90% of stage 4, stage 3, down to stage 1 and stage 2. And as well as reduction in mortality among respiratory disease for the next 5 years, at least we hope 30% reduction, as well as reduction in hospitalization. That is our target for. So in order to achieve that, we need every one of you to be part of it, regardless of where you are or who you are. Then we hope to progress for next coming years to see the impact of this ambitious project. But of course, we need to start somewhere, and we have already started. We have seen some of the success things happening, but we need everything to be in a whole of society approach, as been mentioned by Dr. Eliana. Thank you.
Thank you, Datuk Mat. And last and definitely not least, Dr. Arvin, what about your hopes?
My hope, I think well explained by Dr. Eliana and Dr. Mat, but I'm talking on a clinician point of view. Just that I'm sure many of us will experience that when you go for a hospital level or JKN level meetings, the amount of resources being allocated for respiratory versus, I don't want to offend any cardio colleagues here, cardiology, two different spectrum. We will be getting X, they will get X plus 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 or something like that. So by this lung health initiative, what is my hope is even lung health should be given a similar kind of attention, especially when we are talking about NCD and also communicable diseases together here, like TB plus non-communicable diseases. So but by entire LHI, we hope more resources can be given to primary care plus tertiary care as well, so that early detection, more better treatment strategies, so that we can bring down both morbidity and mortality.
Thank you so much. And that is up for today's session on the Lung Health Initiative. Once again, I would like to thank you, our esteemed panelists, Dr. Matsuki, Dr. Eliana, Dr. Arvin. Thank you so much for your time. And now I hand over back to the chairperson.
Thank you. That concludes our insightful COPD session. Let's once again express our sincere appreciation to all our panelists and speakers for sharing their expertise, valuable perspectives, and time with us today. Their contributions have truly enriched our understanding and inspired meaningful discussion. Please join me in giving them a well-deserved round of applause again, please.
Well, we will now take a short refreshment break and reconvene at 4:20 for our next session on severe asthma. Enjoy the break, and we will see you shortly.
Good morning or good afternoon, everybody. Thank you very much for the invitation, AstraZeneca, to come and speak to you today. I'm hoping you can hear me okay. So over the next half an hour or so, I'm going to be speaking to you about what we've learned really about the role of the epithelium and TSLP in severe asthma. It's a very exciting time in this space. There are lots of new opportunities to understand disease using the therapies we have, and targeting the epithelial health is one of them that's, I think, really interesting. These are just my disclosures over the last 3 years that are relevant. I really want to start by building on some of the themes you've already heard. The epithelium in asthma is obviously the surface that encounters the environment. It is not simply a barrier, it is immunologically active. And when it becomes activated, when patients, for example, inhale allergens they are sensitized to, or where they encounter a respiratory virus, the epithelium becomes activated and releases 3 key epithelial-derived cytokines, IL-33, IL-25, and TSLP, which then ligate to a whole stream of different cells of both the innate and the adaptive immune system, as well as structural cells, collectively releasing even more cytokines, and this is just a small number of them actually that are relevant, because they all drive the downstream pathophysiological processes of areas remodeling, areas hyperresponsiveness, areas inflammation, that then lead to the clinical sequelae of worsening symptoms in quality of life, as well as poor lung function, and of course, in the context of inflammation, exacerbations. Now, TSLP is of interest because actually its receptors are present on numerous cells of both the innate and the adaptive immune system, as well as structural cells. So it really has a very core role across many pathological processes, and we see that when we target it. Perhaps the 2 most important cells in relation to TSLP, when we think about asthma exacerbations and T2 inflammation, are the type 2 innate lymphoid cell, the ILC2, and the Th2 cell. And what is interesting about TSLP and these cells is when it ligates to its receptor, the TSLP receptor, it actually upregulates the receptors of other mediators like the IL-33 receptor and the IL-25 receptor. So it actually enhances the other epithelial-derived mechanisms for downstream inflammation. And therefore, in reverse, if you then target the TSLP receptor or the TSLP itself, the molecule, you then dampen down the effect of the other epithelial alarmins as well. Now, in terms of IL-5 and IL-13, which are the core two mediators released by the type 2 innate lymphoid cell, also IL-4 from the Th2 cell, we see the impact of this when we use tezepelumab that targets TSLP on the two biomarkers that reflect IL-5 and IL-13. And this is, of course, the blood eosinophil count, which is the main biomarker of IL-5, and FeNO, the main biomarker of IL-13. And what you see here from the phase 3 Navigator study, which is shown in the first part on the left, and then continuing with the extension study, the destination study, and then the period off treatment, we can see there's a very rapid reduction in the biomarker level. You can see the axis here is the fold change from baseline. So you're looking at around a 30 to 40% reduction in the blood eosinophil count, similar kind of levels in FeNO that are suppressed. And of course, this is the only biologic we currently have that reduces both biomarkers, remembering that drugs like mepolizumab and benralizumab only reduce the blood eosinophil count mainly. Dupilumab reduces FeNO, but actually can increase the blood eosinophil count, which can lead to some problems in some patients. So this is the only drug that leads to a reduction in both. And in terms of the relationship between these biomarkers and response, we see a very clear relationship. This is data from the most recent of the phase 3 studies called the Direction study that was based in Asia. Firstly, what we see if we look at the placebo arm in gray, both for the eosinophil count relationship on the top and the relationship between baseline FeNO and the exacerbation rate on the bottom, the higher the biomarker, the greater the likelihood that the patient develops an exacerbation in the next year of the study, which is why it's such an important tool to always measure when you have a patient in front of you. Never miss an opportunity to measure the blood eosinophil count and, where possible, FeNO. I appreciate not everybody has FeNO, but it is an incredibly helpful biomarker that, again, relates directly to risk for the patient. So what you can see here very clearly is the higher the biomarker, the greater the risk if the patient is given placebo, i.e. only inhaled therapy. But then you can see the maintained suppression of exacerbations irrespective of the T2 biomarker in patients who are given tezepelumab. Now, this is in relation to exacerbations, but one mustn't forget one of the other really core important aspects of risk for patients is the risk of lung function decline over time. Now, if we look at the biomarkers and the relationship between biomarkers and the rate of lung function decline, we see in a number of studies a very clear relationship. On the left, I'm showing you the relationship between the blood eosinophil count and the change in lung function, and this is shown in FEV1 in mils per year. The higher the eosinophil count, the greater the loss of lung function for the patient. The same is true for FeNO. You can see that very clearly in the middle there. This is a study where, again, they're showing mils per year and a decline in FEV1, and a much longer study on the right, again showing the same thing. The higher the FeNO, the greater the loss of lung function over time. Now remember, some of these patients feel fine. They may say to you, yes, I've got no symptoms, I feel fine. But if you don't measure the biomarker, you will miss that progressive, often irreversible loss of lung function over time. So how does this relate to TSLP in the epithelium? Well, there's a very clear relationship between levels of TSLP and lung function. This is showing the FEV1 as a percent predicted, and the level of TSLP in bronchoalveolar lavage. The higher the TSLP, the lower the lung function of the patient. And we see an inverse of this relationship when we look at the relationship between the eosinophil count on the top, or FeNO on the bottom, and the improvement in lung function when you use tezepelumab. You can see here very clearly, the higher the level of the biomarker, the greater the response in FEV1. And this is very clear as it is with other biologics as well. It's not just anti-TSLP, but there's a very clear relationship. And the question is why? Why is it that the higher the biomarker, the greater the response to targeting TSLP? Well, it in part relates to airways remodeling that goes on in the background, as I've already said. What we know about TSLP is it has a role in multiple processes relating to airways remodeling. TSLP activates lung fibroblasts, and which leads to the production of type 1 collagen. It induces epithelial to mesenchymal transition in epithelial cells. It's important through the upregulation of TGF-beta. It leads to the promotion of the migration and proliferation of airway smooth muscle cells and other mechanisms as well. So it's got a very important role actually in airways remodeling. But this doesn't explain why you would get a very early improvement in lung function when you use tezepelumab, because these processes actually take a little bit longer. To understand why there is an earlier response, one has to look at the impact on mucus plugging. Because what we know about mucus plugging in asthma is that it is a very T2-driven process, involving both the IL-13 pathways as well as eosinophilic inflammation. And this is why there is evidence, actually some evidence for all of the biologics that target both the eosinophil, like with benralizumab. There's a phase 4 study called BURAN, showing an improvement in mucus plugging just with benralizumab. There was also data with dupilumab. So why is it that there is so many responses? Well, it's because all of the aspects of T2 inflammation can be involved in certain patients. And the beauty about targeting TSLP is it has a very broad effect on all of those processes. And so you're more likely to get a benefit in terms of mucus plugging. Now, we see this mechanistically in certain studies that have looked specifically at mucus plugging. One of them is the Cascade study, which is a phase 2 study of tezepelumab. And you can see here when they looked at the CT scans before and after starting tezepelumab, there was a significant reduction in mucus plugging score on the CT scans. A very nice illustration of this was shown in a case study published in the ERS monograph book on asthma. And this is a patient of paramnese in Canada. They used very fancy imaging using Xenon 129 MRI ventilation imaging. And what really this is showing, firstly, on the top here, the top row is before and the bottom row is after tezepelumab. What you can see firstly on the left is the CT images of plugging, shown very clearly with the white areas there within the airway itself, shown in the arrows. And you can see the impact of tezepelumab on the bottom CT scans with the yellow arrows showing a loss of that mucus plugging there. But also in this ventilation defect percentages, which is shown in the images on the right-hand side of the figure, where the more ventilation there is, the more of this kind of blue color there is. And you can see how many defects there are before starting tezepelumab and how much this improves after tezepelumab. So it's very compelling data to show that you can improve mucus plugging and therefore ventilation and airflow through the lungs. One of the interesting findings, which actually we published many years ago, but didn't really appreciate the significance of it at the time, was what patients have most areas of mucus plugging. Obviously, we know there's a relationship with T2 inflammation, but is there any other characteristic that is really associated with mucus plugging in asthma? And what we did is we looked at more than 100 patients who were starting biologic therapy, and we looked at their CT scans, and it was the images were scored independently by 2 different radiologists. And one of the things that really came out was the presence of nasal polyposis. The patients who had high levels of mucus plugging, 45% of them had comorbid nasal polyposis. Why is this of interest? Well, it took a few years later to then see the Navigator study of tezepelumab and the breakdown of the data according to the nasal polyposis. Because what I'm showing you here is data from the phase 3 study Navigator in patients with comorbid nasal polyposis in the darker color, and patients given tezepelumab without nasal polyposis in the lighter color, and then the placebo arms. And what you can see is the patients with the greatest FEV1 improvement were those patients given tezepelumab with severe asthma and comorbid nasal polyposis. And this is interesting then, that's from a lung function perspective. When you look at the exacerbation effect in the patients with nasal polyposis, you see an enhanced effect. In fact, there was an 85% reduction in exacerbations compared to placebo, not compared to baseline, compared to placebo, and an even greater reduction compared to baseline. And this is not simply about, often when you see a percent reduction, it can relate to two factors. One, the placebo, but also the treatment. What you can see here is both is relevant. It's not just the percent reduction is not simply greater because the placebo arm had higher exacerbations. It's also because the actual exacerbation level on tezepelumab was lower. You can see 0.43 versus 1.0, highlighting that TSLP must have a very relevant role in the context of severe asthma in patients with comorbid nasal polyposis. And in fact, what we have seen for many years now is a superior effect compared to anti-IL-5 receptor therapies on the nose itself, not about the asthma, I'm talking about the nose now. This is an example of a patient of mine, and this is from a few years ago now already. On the top, they had already been, we did the CT scan of this patient when they had already been on benralizumab for 18 months. And then we switched them to tezepelumab and retook the CT scan of their sinuses after 6 months of tezepelumab. And what you see is a much better effect overall. This is not because they had had surgery in between or they had any more steroids. This is purely the effect of tezepelumab on the upper airway. And the phase 3 study for nasal polyposis, which is called the Waypoint study, has recently been published, showing very, very good effects. In fact, this is data from all of the different phase 3 studies of all the different biologics. And this here is showing the effect on the nasal polyp score. And what you can see very clearly is there is two standout drugs here. There's basically the dupilumab data and the tezepelumab data with similar results on nasal polyp score. There is actually better results for tezepelumab compared to dupilumab for some of the other endpoints like the SNOT-22 symptom score, but I'm not going to show you that. I'm just showing you this just to really highlight how good tezepelumab is in the treatment of nasal polyposis. Now, one of the other aspects that's important is allergen-induced symptoms. So far, I've been speaking about exacerbations, I've been speaking about lung function, I've been speaking about the effect on nasal polyposis. What about the patients who are atopic and have symptoms driven by allergic sensitization and exposure? What we know, and actually there was a study 10 years before this published by the same author, Gail Gavreau, in the New England Journal of Medicine, which first described the impact of tezepelumab. It wasn't actually called tezepelumab then, it had a different name because the studies hadn't been done, but the same drug, on the allergen challenge. And what it showed was a reduction, a suppression of both the early and late phase response for bronchoconstriction. It showed a reduction in the T2 biomarkers, and it showed a reduction in airways hyperresponsiveness. And this has been consistently shown. If we look at IgE itself, going back to the study I showed earlier, where there was both the phase 3 Navigator study and the 1-year destination extension study, the long-term extension study, and then the period off, it's very interesting because what you see is that the level of IgE falls and actually is maintained for quite a long time after stopping tezepelumab. And this would suggest there is some actually much longer effect than simply the drug half-life on IgE. But nonetheless, what it is showing is an overall suppression and reduction in IgE levels. One of the last things I just want to show you is for the patients with the most severe form of asthma, and those are patients who are dependent on prednisolone, taking prednisolone every single day. Now, the Wayfinder study was the largest of the studies to be done in this group of patients given tezepelumab. There was 300 patients approximately overall, and there are two primary endpoints. The first was the ability to get prednisolone levels down to 5 milligrams or less, and the second was the ability to completely come off prednisolone. And the colors here are showing 6-month data and 1-year data, and what it showed is that 90% of the patients given tezepelumab could reduce all the way down to 5 milligrams or below. 50% of them could completely stop. But actually, there were a lot of patients who the only reason that they were still on prednisolone was because of adrenal insufficiency, not specifically because of asthma. So actually, the overall result is better than this. But what about in the real world? Often in phase 3 studies or controlled studies, the patients are not as severe as the patients we see or complicated in the real world. So this is data from our center we published a year ago or so. And this is 175 patients at Guy's Hospital in London, which is the largest of the asthma centers in the UK, in Europe. And this was in the first 175 patients given tezepelumab. Just to show you the kind of patients, on average, they had 3 exacerbations in the year before and they were poorly controlled. Many of these patients were actually switched from other biologics because of a poor response. And this reflects the idea that tezepelumab has come after biologics like mepolizumab and benralizumab. And so almost half of the patients actually were switched from mepolizumab, benralizumab to tezepelumab because of a suboptimal response. On average, they had an eosinophil count of 300, although if you looked at the eosinophil count prior to the other biologics, it was closer to 500. The FeNO levels were 40, the total IgE was 250. So this is the effect on exacerbations. And on the left here, I'm showing you the exacerbation rate in panel A. The red-pink color are all the patients, 175 patients. The light blue color are those patients who had tezepelumab as their first biologic. These are the biologic naive patients. And then the dark blue color are those patients who switched from, in most cases, mepolizumab or benralizumab to tezepelumab. What you can see is a very significant reduction in exacerbations. If you just look at the biologic naive patients, their baseline exacerbation rate was over 4, and it falls to below 1 after 1 year. In panel B, what we see is the number of patients, the proportion of patients who become completely exacerbation-free, totally stop exacerbating. And you see both in the biologic naive and in the patients who had to switch because they were still having on average 2 exacerbations on the biologic they were on, 60% of them completely stopped exacerbating when they were switched to tezepelumab after a year of therapy. So a very impressive result, especially in patients in whom, although they have severe asthma and T2 inflammation, the eosinophil for those patients appears less dominant, and actually targeting the other aspects of T2 inflammation appears more clinically relevant for those patients. Now, the responses we see is slightly variable based on the level of T2 inflammation at baseline. And this is now showing the remission rates that we see. Clinical remission I've shown here in 4 domains on the left, and the bottom left of the slide, you can see the different domains that are required. You need to have good symptom control with an ACQ less than 1.5. You need to have completely come off maintenance prednisolone for asthma. You need to have 0 exacerbations, and you need to have stable FEV1, and stable was no more than a 5% change in FEV1. And you can see that if we set the bar at 3 or 4 of these domains being met, 60% of patients achieved that. More than a third of patients achieved all 4 domains. But what you can see on the left is the likelihood of achieving that level related to the baseline level of T2 inflammation. So on one hand, in patients who, for example, had a FeNO less than 25, i.e. no evidence of T2 inflammation, those patients, there was only 12% achieved remission. In contrast, in patients who had a FeNO of 50 or more and an eosinophil count of 300 or more, 0.3 or more, 55% of those patients achieved complete remission. So the response you see very much depends. One of the last things I just want to mention is very important because it relates to how quickly one needs to start biologic therapy. There was a really important study by my colleagues in Belfast where they looked across multiple studies of biologic therapies and remission rates to see what is it that really leads to greater remission rates apart from simply T2 inflammation. And one of the things that really came out was the patients that had worse lung function at the beginning, those patients that had had asthma the longest. And this is important because often there is a delay in starting biologics, an avoidable delay. I appreciate it's hard if patients can't afford it or if there's a problem because of the threshold of how many exacerbations you need, but I'm talking about patients who are eligible and yet they are still delayed, because there is a window with which to act before you lose lung function. And this, I think, is summarized in this figure. And the idea is that there is ongoing disease activity that fluctuates. There is peaks and there is troughs with exacerbations and quieter periods. But if you do not act within a certain amount of time, this inflammation, which is driving these exacerbations, will lead to ongoing remodeling of the airways, increased comorbidities because of the steroid courses that the patient has, and other aspects of immune remodeling. And you are not going to get the kind of benefit you would get had you started earlier. And this is really important about the impetus to start biologics as soon as possible. So to summarize, what we have to always remember is harm in asthma comes from 2 or 3 core areas. The key thing is a failure to control eosinophilic and T2 inflammation. The second thing is the harm from the steroids. The patients we see, if we keep on giving them courses of steroids without appreciating the damage it's doing, we will end up harming our patients to a great degree. Now, these, of course, are linked because the more T2 inflammation you have, the more exacerbations the patients develop, the more steroids they need. But as I showed earlier, another really important aspect relates to lung function decline. Even in patients that have fewer exacerbations, they will be at risk of progressive loss of lung function if you do not control that T2 inflammation. And then that lung function becomes irreversible. And when you eventually start that biologic, as I've shown you, you are not going to get as great a benefit as you would have had you started more promptly. So that is my take-home message. And I'd like just lastly to thank my team. This is my team in London at Guy's Hospital. Much of the data I've shown you today was collected and analysed by my team. So thank you very much, and thank you again for the invitation to join you today.
Thank you very much, Prof. David, for sharing your expertise and valuable perspectives with us. My apologies, we did actually miss talking about your biography earlier. Let me just introduce you again to our participants today. Professor David Jackson is a professor in respiratory medicine in King's College London and clinical lead for the severe asthma and eosinophilic lung disease service at Guy's and Royal Brompton Hospital in London. Dr. Jackson has a Master of Science in Allergy and a PhD in the Pathophysiology of Asthma Exacerbations from Imperial College London. He has published widely in the field of type 2 immunity, biologic therapies and asthma, and EGPA and the mechanisms of exacerbations of these conditions. He is chair of the British Thoracic Society Asthma Advisory Group and associate editor at the journal Thorax and Allergy, and editor of the ERS monograph books on eosinophilic lung disease and asthma. He is the director of the ERS course on eosinophilic lung diseases and was awarded the ERS Gold Medal in Asthma in 2025. I thank you very much again for your time with us.
Thank you.
Next, I would like to invite Prof. Dr. Martha Marin Otto again to share her perspectives on expanding horizons in asthma, the emerging role of triple therapy. Please join me in welcoming our speaker. Over to you, Prof. Martha.
Thank you again for having me for this additional talk. Now I will try to explain this emerging role of triple therapy after Professor Jackson has beautifully told us about the role of biologics and specifically TSLP role. So this is the agenda I'm going to follow for the next 15 minutes. So we'll start with a little bit of the burden of asthma. As we know, although asthma is often considered a controllable disease, it continues to represent a major global health burden. More than 260 million people worldwide are affected, and exacerbations remain a major driver of morbidity, mortality, and healthcare costs. Therefore, our goal today should not only be symptom relief, but also reducing future risk. And the challenge is that many patients who appear controlled may still have a significant disease burden. So one important issue in asthma, I would say, is the mismatch between patient perception, how the patient feels, and objective disease control. Many patients adapt their lifestyle and underestimate their symptoms. And when we apply objective criteria in our clinic, in our day-to-day basis, a substantial proportion still report liver use, nighttime symptoms, and activity limitation. So asking, are you doing well, sometimes is not enough. This is clinically relevant because poor control is not only about symptoms today. Persistent symptoms, overuse, and exacerbations identify patients at a higher future risk, as we can see in the slide. Importantly, exacerbations are not isolated events. They are associated, as we can see in the right part of the slide, with accelerated lung function decline. This is our GINA recommendations. ICS-LABA remains the cornerstone of asthma management. And as we know, GINA recommends a stepwise approach, even when symptom burden and exacerbations still dominate the setting. Likewise, a little bit with COPD, as we used to do. For steps 1 and 3, or steps 1 through 3, irrespective of the track that we choose, low-dose ICS with or without LABA stands as the main treatment. And as for steps 4, medium-dose ICS plus LABA is indicated, and per step 5, LAMA is added, usually plus a personalized approach through biologics, or even considering high doses of ICS. However, if we can look at the right part of the slide, even among adherent patients receiving medium or high ICS LABA, a relevant proportion remains uncontrolled, 64% versus 36% that say that remain, and we object that remain controlled. So despite this, I just want to make a highlight in a detail is that GINA now recommends triple therapy as a safe therapy for patients above 12 years of age. This raises an important question. Are we fully addressing all treatable mechanisms driving asthma? So when we talk about optimizing asthma treatment in the past, escalation was frequently assessed as increasing corticosteroid exposure. However, asthma is heterogeneous and different mechanisms require different strategies. Before moving beyond inhaled therapy, we should ask ourselves and our patients whether inhaled treatment has been fully optimized. Triple therapy and biologics should not be considered competitors, but complementary approaches targeted different treatable traits. So moving a bit forward in the ICS ceiling effect, one reason why alternative pathways are needed is the dose-response relationship of inhaled corticosteroids. ICS, we know, provides major clinical benefit, especially at low and medium doses, but the curve, if we see and we look at the slide thoroughly, tends to plateau. Moving from medium to high doses usually provides limited additional benefit for many patients, while systemic exposure and adverse effects increase. Therefore, if we analyze the ceiling effect we were talking about, escalation does not always mean more corticosteroids. Once inflammation is appropriately addressed, persistent symptoms or risk may reflect other mechanisms that increase that systemic exposure. So this is where adding a different mechanism such as LAMA, for example, can make a significant difference in our patients. As per GINA, high-dose ICS provides minimal additional benefit with increased risk of some side effects. When stepping up from medium dose to high ICS provided little additional benefits in most patients in some studies, like, for example, 35% increased risk of worsening asthma or an 70% increase risk of exacerbation. Comparing with patients with no steroid use, long-term use of medium dose ICS is associated with reduced risk of adverse events, whereas high-dose ICS is associated with increased risk of adverse events such as an increased risk of pneumonia or osteoporosis. So why should we target the muscarinic pathway? Well, let's talk about the potential impact when we add LAMA. One of the additional mechanisms we should talk is the cholinergic pathway. The addition of LAMA has been shown to have a reduction of bronchoconstriction, an impact on mucociliary clearance with the reduction of mucus hypersecretion, and a possible, still exploring, anti-inflammatory and anti-fibrotic effect. LAMA, as I was saying, provides a complementary mechanism to LABA by blocking the M3 receptors and reducing airway smooth muscle contraction. Beyond bronchodilation, muscarinic signaling may also influence that mucus hypersecretion and some airway structural changes, and therefore adding a LAMA is not simply adding another bronchodilator, it can target a different biological pathway, not overlapping the ICS LABA mechanism. So what do we know so far? What have we learned from previous evidence? So the updated meta-analysis from Reiner and colleagues, including more than 12,000 patients with moderate to severe asthma comparing triple versus dual therapies, provides several important messages. First, I think, in my opinion, the most consistent benefit of triple therapy is the reduction in severe exacerbations with approximately a 17% relative risk reduction. Second, improvements in lung function, symptoms, quality of life are present, but generally in previous studies are modest. This distinction is important because the main value of triple therapy may not be making every patient feel dramatically different tomorrow, but reducing future risk. And last but not least, these benefits appear consistent across different patient characteristics, supporting a broad role for triple therapy. However, despite this evidence, an important question has remained. And what is this question? The question is, what happens when triple therapy is tested in a broader population reflecting real-world asthma evidence or real-world asthma patients? This is, I think, where we can talk about the new study, the Kalos and Logos study, and these studies can provide new important evidence. Kalos and Logos, as you may know, were two replicate phase 3 randomized double-blind studies that evaluated the BGF in patients with uncontrolled asthma despite medium or high-dose ICS LABA. Importantly, patients were included regardless of exacerbation history, allowing the evaluation of a broader asthma population. These studies assess both components that matter in clinical practice, which are lung function and exacerbation prevention. The first important point when interpreting these two studies is to understand the population that was included. I've just talked about a little bit before. These were not patients starting asthma therapy. These were patients with persistent unmet need despite currently recommended treatment. Patients were adolescents and adults between 12 and 80 years of age with inadequately controlled asthma despite treatment with medium or high-dose ICS LABA. Importantly, inclusion was independent of previous exacerbation history, which is an important fact, which allows us to evaluate triple therapy in a broad population than only the classical frequent exacerbation phenotype. All patients had evidence of uncontrolled disease with an ACQ-7 score of at least 1.5, impaired lung function, and documented reversibility. The studies focus on outcomes that are relevant in our clinical practice: lung function improvement, measured by the change from baseline in morning pre-dose trough FEV1, and second, the annualized rate of severe exacerbations in the pooled analysis. So essentially, the question was, can adding a LAMA provide additional benefit in patients who remain uncontrolled despite ICS LABA therapy? So for the first key result, the effect was on lung function. BGF demonstrated a statistically significant improvement, as we can see on the slides, compared with ICS-LABA combination. Looking specifically at the primary lung function endpoint, the improvement was more in pre-dose trough FEV1 over 24 weeks, and this showed a difference, a mean significant difference of 76 mLs compared with ICS-LABA. Importantly, this benefit was not limited to trough lung function. When the under the curve FEV1 was evaluated from 0 to 3 hours, which reflects the bronchodilator effects after the treatment administration, the difference was even greater, approximately 90 mLs. These results, I think they reinforce the biological rationale we discussed earlier. Of course, the magnitude of the FEV1 improvement should be interpreted realistically, but it demonstrates a consistent and measurable physiological effect of triple therapy. Apart from lung function, the other important endpoint were exacerbations. As we discussed, one of the main goals in asthma management today is preventing the future risk, especially severe exacerbations. In the pool analysis of both CALOS and LOGOS, BGF significantly reduced the annualized rate of severe exacerbations compared with ICS-LABA, and the rate ratio was 0.86, corresponding to a 14% relative reduction in severe exacerbations. In addition, the time to first severe exacerbation was also prolonged with triple therapy, and this is again clinically relevant because we know, and this is a fact from other studies, that exacerbations are associated with systemic corticosteroid exposure, healthcare utilization, and long-term consequences, including accelerated lung function decline. So the value of triple therapy should be viewed not only as improving lung function today, but also as reducing the future risk for exacerbation. Another interesting aspect is the time to onset of action, this rapid effect of action. A significant improvement in FEV1 was already observed within 5 minutes after the first dose. The mean improvement from baseline at 5 minutes was 170 mLs with BGF compared with 136 with LABA ICS. And beyond spirometry, this may also be meaningful for the patient perspective and symptom control and exercise capacity. In the onset of effect questionnaire sub-study, approximately 74% of the patients receiving triple therapy reported perceiving an effect within 5 minutes after treatment administration. And when moving from physiological endpoints to patient-reported outcomes, PROs, improvements in asthma control were also observed. With BGF, ACQ-5 scores improved rapidly within the first 4 weeks, and this improvement was sustained over time. At week 24, approximately 73% of patients receiving triple therapy achieved a clinical meaningful response defined as an improvement of at least 0.5 points. However, it is important to interpret these data again in context. Similar improvements were also observed across treatment arms. Therefore, the overall benefit of triple therapy appears to come from the combination of lung function improvement, exacerbation reduction, and maintaining the good symptom control. Finally, whenever we intensify treatment or we change any treatment for our patients, safety becomes a key consideration. In both CALOS and LOGOS, the overall safety profile was reassuring. The frequency of adverse events was similar across treatment groups, with the most common events being upper respiratory tract infection and nasopharyngitis. And importantly, adverse events typically associated with LAMA therapy were uncommon. The incidence of LAMA-related adverse events was low, below 0.5%, and consistent across groups. Therefore, these data suggest that adding a LAMA, in this case glycopyrronium, provides additional clinical benefits without introducing a relevant additional safety burden. So to conclude, again, 6 bullets as take-home messages. Despite advances in asthma management, many patients still remain uncontrolled on ICS-LABA with symptoms and risk of exacerbations. Treatment escalation should not simply mean increasing ICS exposure. Targeting complementary pathways, in this case, the use of LAMA, can represent an opportunity to optimize asthma care. Adding a LAMA provides a complementary mechanism to ICS-LABA, addressing other pathways. Current evidence shows that triple therapy significantly reduces severe exacerbations with modest improvements in lung function, symptoms, and quality of life, and without increasing the adverse events. And both CALOS and LOGOS can expand the evidence base by evaluating the single inhaled triple therapy in a broader asthma population closer to patients that we may encounter in clinical practice. And triple therapy represents an important step in precision escalation, optimizing inhaled treatment before or alongside with the phenotype-driven advanced therapies. Thank you very much, and I'd be happy to answer any question later.
All right, thank you very much, Prof. Marta, for that engaging and informative presentation. Next, I would like to invite Prof. Dr. Ernest Poh Mau Ern to present eosinophils under siege, strategies to eliminate OCS. Please join me in welcoming Prof. Ernest. It's also my pleasure to introduce you to Prof. Professor Dr. Ernest Poh is a senior consultant and head of the Respiratory Medicine Unit at UMMC. He is the leading expert in bronchiectasis, COPD, and lung cancer, with a special interest in advancing lung oncology through chemotherapy, targeted therapy, and immunotherapy. A respected clinician researcher, Prof. Poh has led numerous clinical trials and published widely in leading medical journals. He is also a co-founder of the National Lung Cancer Disease Registry and plays a key role in shaping lung cancer care and guidelines in Malaysia. In addition to his clinical and research work, Prof. Poh is actively involved in medical education, mentoring future healthcare professionals, and serving as a trainer and examiner in respiratory medicine. Over to you, Prof. Ernest.
Thank you. Thank you for the introduction, and thank you, AstraZeneca, for the kind invitation to speak today. So I'm given 20 minutes to talk about data and to share a case. I'm sure all of you are a little bit overwhelmed with all the data that's been presented over the past 2 hours. We are a bit data overload. So I hope the case would actually generate a little bit of interest into what we see day to day in our real life practice. So these are my disclosures. So basically, we will talk about eosinophils and severe asthma. What is the mechanism of action behind benralizumab? I'm also going to introduce you to another study. I know you've got so many studies on board, but Penantes study and the case study that I talked about earlier. So a very quick introduction. I think it is good to refresh our mind again of what is severe asthma. About a quarter of our patients with asthma require quite high intensity treatment. They require, for example, a medium or a high dose ICS-LABA. So somewhere around GINA step 4 and 5. But when you come to think about difficult to treat asthma, actually the proportion, when they did it in this study, showed it's a little bit around 17% or maybe a fifth of our patients have difficult to treat asthma. And these are patients that are on GINA step 4 and 5, and yet they still have poor symptom control. But there may be certain things that can be controlled or modified in order to treat this asthma. For example, a very common cause that we look for is whether they're using the inhalers correctly. So we check their inhaler technique, we ask them whether they are adherent to their medications, and we also check for comorbidities such as gastroesophageal reflux disease, obesity, bronchiectasis, and all sorts of other comorbidities, okay? So once you address these comorbidities, if you're able to control the asthma, then these patients are not severe asthma, okay? But if once you have addressed all these other factors and yet the patients have poor symptom control, then actually you can see the patients with actually very severe asthma, the proportions are actually very small, okay? In this study, only 3.7%. So telling us that difficult to treat asthma can be treated if we address the modifiable and risk factors as well as the comorbidities. So if the patients really have severe asthma, a lot of time their lifestyle, their daily activities will be impacted. And there's a huge disparity again, I think Prof. Marta has showed you just now of what patient perceive as controlled versus what GINA defines as control. But a lot of them despite being compliant to their medications, GINA step 4 and 5, they will still have exacerbations, they will still need hospitalizations. Majority of them have a higher mean eosinophils, and they also likely have some history of atopy in their history, okay? So, when we look at the International Severe Asthma Registry, almost about 84% of severe asthma patients, remember that small proportion of patients that we talked about, were most likely to be eosinophilic in nature. And these can be seen if the patients have an elevated levels of blood eosinophil counts of more than 300. But bearing in mind, these patients may have had short bursts of oral corticosteroids along the way when they develop exacerbations. So when you measure just one hand, just on a one-time basis of blood eosinophil counts, this may not be actually reflective of the patient's baseline blood eosinophil. So bear in mind, the patients may have had OCS at some point or another. If also they are on step 5 and yet on step 5 they remain on maintenance OCS and they use the oral corticosteroids to control their symptoms, they are also mostly eosinophilic. In addition, there are also certain features that may suggest an eosinophilic disease, such as an elevated FeNO, although FeNO is predominantly driven by IL-33, which Prof. Jackson showed you earlier, but there are also things like nasal polyps, which shows a broader type of type 2 inflammation, as well as a later onset of disease. So this inflammatory pathway is not foreign to us. You've seen this a few times this afternoon. I think Prof. Jackson also showed it just now. But basically, just to highlight the cascade here, where you have your triggers right on top, and these triggers off alarmins such as TSLP, which Prof. Jackson talked about just now, IL-33, and this cause a whole cascade that eventually leads to IL-5 production, as well as activation of your eosinophils. So asthma is definitely not just a single form of inflammation. It is a broad form of type 2 inflammation that can span from allergic inflammation all the way to eosinophilic and all the way to airway hyperresponsiveness, as well as mucus productions and mucus plugging, as Prof. Jackson showed you just now. Okay, so increased airway eosinophils are strongly associated with increased asthma severity. I think all of us know that. Even from medical school, we are taught to check the blood eosinophil counts for patients. Airway eosinophilia persists despite we using, for example, even triple therapy to treat severe asthma patients. Approximately 50% of them will still have some airway eosinophilia. And over time, if we don't act on these blood eosinophils or airway eosinophils, this will lead to decline in lung function. Remember that graph that Prof. Jackson told you just now? If you miss the window of opportunity to treat them, the patient will have airway remodeling and therefore fixed airway obstruction. So exacerbation risk rises with eosinophils and not with IgE. So this graph shows you, despite having high levels of IgE, the risk of exacerbations remains quite plateaus throughout, but when your eosinophils goes down, looking at the blue line on the right, if your eosinophils counts goes up, the higher your eosinophils, the higher your risk of having an exacerbation. And so we also know, so again, a different slide that shows you the higher your eosinophil counts on the left, the increased risk of you having an exacerbation and having a decreased control of your asthma. Okay, so this again shows you if you have higher peripheral blood eosinophils, over time, as I mentioned just now, with the airway remodeling and all, your lung function will decline. So we have talked about anti-TSLP just now, tezepelumab. We've talked about triple therapy, and so now we're going to talk about IL-5 alpha. So this is benralizumab, and so how does it do? It is an interleukin 5R receptor alpha monoclonal antibody that directs the NK cell to attach and to, that directs the NK cell, it recruits the NK cell, and it directly targets the IL-5 receptor alpha on the eosinophils. So this leads to this condition called ADCC, which is antibody-directed cytotoxic cell-mediated cytotoxicity. So the NK cell is actually harnessed to destroy the eosinophils in the peripheral blood system. Okay, so this leads to complete depletion. There's 100% reduction in the eosinophils in the blood. And also this also translates to other parts of the body as well, in the bone marrow where the eosinophil precursors are produced, in the sputum as well as in the lung. So we know that across the world, depending on where we are working at, probably higher prevalence in Southeast Asia, a lot of people are actually using an oral form of medication to control their asthma. Just this morning, I had a patient who came to me and saying that her inhaler is not working. She wants oral salbutamol, right? So we are very commonly encountered, even though I've not used oral salbutamol in 15, 20 years of my life, but then this patient still comes insisting that oral salbutamol, oral prednisolone works better for her than her inhalers. Okay, so this is not uncommon. We see that very much. They come in, they want something oral. It's easy to take. They will feel much better after taking it, okay? So, but we also know taking this on the long-term basis will lead to all sorts of adverse events, okay, including development of diabetes, osteoporosis, cataracts, and so on and so forth. So the list continues. And we know as well from studies that as little as 2 to 4 lifetime courses, that means each course, for example, patients come in for an acute exacerbation, you give them, for example, 30 or 40 milligram per day for a week or for 5 days. If you accumulate that to 2 to 4 times, you have an increased risk of developing diabetes, pneumonia, osteoporosis, and the risk actually goes up even higher the more oral corticosteroids patients use, okay? So now in GINA, they actually acknowledge that even if you use 4 to 5 lifetime oral corticosteroid courses, your risk of osteoporosis, diabetes, and cataract increases. And if you accumulate them cumulatively, you will have more and more problems as you go along. And so that's why in GINA, the statement now is that OCS should only be ever used as a last resort. Once we have optimized inhaler therapy, then if the patient still remains uncontrolled, and then we should look at modifiable risk factors, comorbidities, address adherence, address inhaler techniques, and then we need to start thinking about biologic therapy. Okay, so that's how biologic therapy comes about. They are effective. We will talk about how to taper OCS in a while, but the approach should be individual, and we always have to bear in mind of patients having adrenal insufficiency if they've been on OCS for a very long time. So here comes Ponente's study. I know it's another study now to bog your mind with this afternoon. I hope you have not fallen asleep. So basically, this is looking at how we reduce oral corticosteroid in patients with severe eosinophilic asthma with benralizumab. And this is how the study was done. So patients were enrolled and given the first dose of benralizumab. They had to be on stable OCS. There was no tapering in the induction phase. And then in the reduction phase, the OCS was reduced over a couple of weeks. And then in the maintenance phase, there was no further OCS down titration, and they observed what happened to the patient, whether they exacerbated or not, okay? So just a very quick one, study population we've already gone through. These patients had more than 5 milligram per day of prednisolone for more than 3 months, and their OCS dose is stable for 4 weeks prior to entering the study. They also had a raised peripheral blood eosinophil counts of more than 150 or more than 300. As you know, eosinophil counts actually fluctuates over times. And not to go too much into detail, but basically, if the dosage of the prednisolone is very high at more than 20 milligram, then the down titration happens a lot faster. They do that reduced by 5 milligram every week, followed by every 2 weeks once they reach 10 milligram, and then after that 2.5 at 7.5 milligram, and then down to 5 milligram, at 5 milligram, the patients have been on all this chronic OCS. We also have to worry about whether they have adrenal insufficiency. So we will do an early morning cortisol test, and then we will see whether the levels are low or normal, and then you can decide whether to taper down further, depending on whether the patient really have partial or complete adrenal insufficiency. Okay, so this was just a group of patients, predominantly female. Okay, they have, you can see that their median OCS dosage was about 10 milligram up to, but the range, patients could be on 60 milligram a day for more than 3 months. So you can see these are very, very severe patients, included them. They also had, about 60% of them had some form of allergy, okay, and 30% had chronic rhinosinusitis with nasal polyps. So at median baseline, as I told you just now, it's about 10, but the range can go up all the way to 60 milligram, and the median baseline blood eosinophils was about 230. But in about 62.9% of them were able to reduce their OCS dose. But if they wanted to, you wanted to include those that have reduced to less than 5 milligram, that means they were on 5 milligram and complete reduction, then the percentage were much higher. So this 81.9 includes those with 62.9 plus the patients who remain on 5 milligram because they had adrenal insufficiency, not because we couldn't reduce it. So about 80% of them you can actually bring it down all the way down to 0 or to 5 milligram, but the 5 milligram is not capped because their asthma is not controlled. It is because they have adrenal insufficiency. Okay, so I'm not going to go through too much in detail, but basically, irregardless of what OCS dose the patients have, a big proportion of them actually could achieve a daily dose of less than 5. Okay, so what happens during the reduction phase? We also wonder, is it safe to reduce the steroids when patients are on benralizumab? Will they exacerbate? Well, about 75% of patients remain exacerbation-free during the OCS reduction phase. About 25% of them did have one exacerbation, but when they actually reach to the maintenance phase, when benralizumab is given every 8 weeks, then you can see that a big proportion of them, almost 84.5% of them, did not have an exacerbation. Okay, and the patients, of course, had a better asthma control questionnaire score and also had a significant improvement in their St. George's Respiratory Health Questionnaire score. Okay, now, patients who were on corticosteroids for these were patients for more than 3 months, you can see that adrenal insufficiency is more common than we think. It's about 60% in this study. So it's important when patients have been on steroids for a long time before we taper down, and also when we taper down to about 5, we need to remember to check their cortisol, okay? Because they can fall into that 60%, and you don't want them to come with an Addisonian crisis, right, to the ED department. So just a very brief dosage. How we reduce, it's also available on the MTS website. We start fast if their dosage is above 20 milligram, and then we gradually slow it down as we reach lower and lower doses. Okay, so this is just a summary, and it's also there on the website if you need to refer. So basically, it just shows you that Ponente was able to reduce a lot of the patients with severe asthma, with chronic OCS for more than 3 months. Okay, you reduce them as fast as you can, but when you reach a dose of 10 milligram or lower, you start to taper down very slowly, and you always remember to check their cortisol levels, okay? So just a very quick one for the case. Where am I with time? Oh, okay, that very quickly. So I've got a 43-year-old, he's a police officer, and never smoker, but he has childhood asthma. He's quite fit. No allergic rhinitis, strong family history of asthma. His whole family has asthma, actually, right? And he's married with 4 children, all with asthma. Okay, so very, very, very strong history, okay? His severe exacerbation in 2020, and he was intubated, okay? Then his wife came and see me, and she was like, oh, like, I cannot. She was so traumatized, okay? Intubated, ventilated, and initially started on ICS LABA and Montelukast, okay? Subsequently, despite being compliant with good inhaler technique, he continued to have multiple exacerbations, but not as bad as the one in 2020, okay? So this is our patient. At baseline, his eosinophil counts, when I first checked him, his eosinophil counts was only 290, okay? Then as I checked him at multiple points, the highest he reached was about 900. Okay, so telling you that eosinophils can change over time. Remember to check at different time points. His serum Ig was not high, and his FeNO was 33. Okay, so other things was okay. You can see his lung function is already reduced at that time. His HCT score was not great with 15, and he was given LABA-LAMA as well as ICS-LABA and LAMA and Montelukast as well. Okay, so X-ray done. This is quite okay. And this is how we are. He was already actually on step 5, right? Because he's on triple therapy as well. So this is his management then. He was currently on triple therapy. He was using daily SABA. He was still feeling exertional dyspnea, very symptomatic, still had multiple exacerbations requiring multiple bursts of OCS. So what would you do? I know we are very short of time, but do we still want to put that on? Okay, let's do a quick poll, okay? Otherwise everybody will be falling asleep. So if you are still on Slido, you can use that to vote. I'm not sure whether a lot of you are still on that. So you can choose to go on breast tree. No. No indication yet. Okay, but you can choose to use triple inhaler, triple therapy. Okay, would you start prednisolone, theophylline? Okay, in the interest of time, I think we will stop here. There's about 40 and still growing. Okay, but a lot of you would choose to switch to a single inhaler therapy. Possible. Okay. But what I did was I did a HRCT thorax first. Remember, he has severe asthma, but we need to think about whether he's got other things going on, other comorbidities. Okay, inhaler technique okay, adherence okay, he's compliant to it, he's had a previous intubation, he doesn't want to end up in the ICU again. HRCT thorax was normal. Okay, so I switched him to receive this single inhaler therapy, also continue on Montelukast. Okay, despite that, about 4 weeks later, again, he was admitted to a private center for acute exacerbation. He said he feels breathless most of the time. This time, he was discharged with oral pred again. But this time, he decided that it made him feel so good that he wanted to remain on it for a little while longer. Okay, so he tried to reduce prednisolone to about 20 milligrams. But he said the minute he reduced anything lower, he would feel breathless again, the cough would come back. Okay, so over 6 months, he remained on oral prednisolone. Okay, he said, I just got it over from, it's cheap. I could get it from the pharmacy or the nearby primary doctor. I just continued on it. And then he every time he tried to reduce to below 20 milligram, he would end up in the emergency department, okay, for an exacerbation. So 6 months later, this is him. He has put on significant weight because of the prednisolone as well, and also because he's not been exercising much. He's just too breathless, and you can see there's a bit of his fasting blood glucose is a bit high. Okay, HbA1c about 6.4%, but it's affecting his job now. It's bad. He's put on weight despite being on the steroids, trying to control his symptoms, but it's affecting his training. And so this is him, and he's highly symptomatic despite being on steroids. So what treatment would you plan? I think in the interest of time, let's not vote here, okay? Because I think, do you want to vote? You want to vote? You want to vote? Okay, let's vote. Okay. I'm sure AstraZeneca is also interested to see what you pick, right? Nobody picked D. If you pick D, maybe dinner is not free for you later. I'm just kidding. Okay. Okay, wow, so a lot of you will pick benralizumab, so I've done my talk well. A lot of you know what's the biologic of choice, although I think Tezi is also a good choice, all right? Tezi also works in a broader type 2 inflammation. So these two are there for you to pick. So he was started on benralizumab. And again, now he started, so during the induction phase, he started inquiring about tapering because he was feeling better. He said he feels so much better. ACT had gone up from 15 to 19. He doesn't need to visit the primary care or the ED doctors anymore. And this is just how we tapered. So I tapered at 5 milligram each week, and then until 10 milligram, and then I switched it down to 2.5. And you can see after he was taken off the prednisolone, he actually, in between now, in the maintenance phase, he actually had an exacerbation, where a mild one, where he had to visit the GP. He belongs to that 25%, remember, that I showed you in the parental study that had an exacerbation during the maintenance phase. But he rarely uses SABA anymore. He said if he exercises, he still gets breathless, but he's so much better than before. Okay, so you can see his ACT score has gone up significantly. He has only one exacerbation while on the maintenance phase, and he feels much better. Because he took off steroids, his weight came down, and he feels much less breathless when he does his training and work. Okay, so that's my case, and thank you for your attention. I'm sorry I went out of time a little bit.
All right. Thank you, Prof. Ernest, for that comprehensive overview and expert perspectives. May I kindly invite Prof. Ernest to remain on stage for our next segment. Then now, let's welcome Prof. Martha again back to the stage for our Q&A session. And once again, for those who would like to ask questions, you may ask directly or you can post your question through Slido. We will now open the floor for questions.
Prof, if you don't mind me starting off, just coming back to the case that you presented earlier, if let's say financially it's not a problem for you to apply for the patient to have biologic a bit earlier, would you have waited for the steroid to be started, or would you prefer to give the biologic first before having the patient on regular steroids?
I think if financially he had a bit of delay because we were actually considering biologics at that time, and he needed to get the approvals and the funds and everything. So initially, I guess if there is a choice, obviously OCS should always be the last resort. But I think we had quite a serious discussion then. He was feeling better with the 10 milligram twice a day steroids. He already had a very traumatic episode where he was ventilated. He didn't want to get that again. Every time he goes to the emergency, he never knows whether he will come out from the emergency. So those were the factors that we had to discuss. At the end of the day, the decision, obviously, as physicians, we will not encourage to remain on that, and we will try and give you a better drug. But at that point of time, I think that was the best decision for him. Yeah.
I think we have questions from the audience.
Yes.
Is Prof. Martha still around? Yeah. Okay.
Is there episodes of depression, suicidal tendency with the chronic use of Montelukast? And the other one is use of magnesium, the use of magnesium in severe asthmatic attacks.
Okay, so depression, of course, is one of the black label warning for Montelukast. I think we try to get patients off after a certain amount of time, and if they can be optimized on inhaler therapy. But I think in our own experience, or even some of my colleagues here who are very, very much experienced, I think we hardly have anybody who has very severe issues with Montelukast. So, of course, we are aware of that black label warning, and we are aware that patients should not be on Montelukast beyond a significant period of time. Usually, I say about 6 to 9 months. But we do also have patients who rely on that just because they have no access or they have limited funds to more advanced therapy. And so that is the best thing at that point of time to be on. But okay, yes, you're right. We need to be watchful, and we need to be aware that if they do develop depressive symptoms, I always also assess them. How are they feeling when they come and see me, if they are on Montelukast for a long period of time? So yes, those are important things to bear in mind. You're right. Magnesium as a control, I don't think we have. I'm not sure. I'm not aware. Maybe Prof. Martha would know. Is there any studies that we use magnesium? But of course, in the acute exacerbation, we do give magnesium sulfate as a acute, when they come in for the acute exacerbation. But chronic usage of magnesium, I'm not too aware of any studies. Prof. Martha?
Yeah, thank you for passing over. Totally agree. There are no studies favoring magnesium for chronic use. We only use them in the acute care setting, especially in the ICU when you have monitoring of the patient.
With the use of steroids, prolonged use of steroids, do you have cases where depression or psychotic tendencies?
Yes, we definitely do have, especially on patients on high-dose steroids. Yes, there are areas where patients are very depressed, and we needed to refer them to our psychiatry colleagues to manage their depression. So I definitely have come across a number of patients who have to be on oral corticosteroids. It was even before the era of when we had biologics, where we actually treated patients. If you remember last time, the OGNA, it was always step 5 oral OCS. It was during those era when we used a lot of OCS that we actually do come across a lot of these patients.
Okay, we have a few questions from Slido. Probably one of the questions quite significant. So for patients with for patients still uncontrolled on medium or high dose ICS/LABA, what are the criteria to choose triple therapy over a biologic? Probably Prof. Martha can give us an insight.
Sure. This is a great question. And I would answer saying that triple therapy it's not about triple therapy or biologics. I think it's a combination of both. We need to assess very thoroughly the phenotype of the patient we're facing. And I think that when we are thinking about the phenotype and what is the best treatment we can give a patient, we need to have him in the best triple therapy we can give him, or best inhaled therapy we can give that patient. And I would say that we need to focus on using triple therapy for especially severe asthma uncontrolled patients, but they are both complementary treatments. You do not have to choose one over the other. But I guess I would say that when thinking about putting a patient on a biologic, these patients should be previously on triple therapy.
Right. Thank you so much, Prof. Martha. I think one of the questions also quite relevant to our practice. Probably we'll start from Prof. Martha. If you want to subject a patient for a biologic, would you consider to refer to immunologist first before initiating or choosing a certain type of biologic? Thank you.
This is a great question, and I think it's very appropriate. In Spain, in my practice, we have, before we start a patient on a biologic, we have a committee that is composed by respiratory physicians, ENTs, and immunologists. So we do this big meeting, we present the case, and all of the specialists taking care of the patient decide what is the best for the patient. So I think, yes, it is very important to have an immunologist on your team.
I guess the next question would be to Prof. Ernest, if you don't mind. For patients with triple high, would you go straight to block at the top rather than going at the bottom? What do you reckon?
So this is a very good question and a very common question that I think anybody who's speaking in a severe asthma talk would get. So I think it's important to bear in mind that these are all biomarkers. When we measure eosinophils, IgE, FeNO, and we are not targeting individual biomarkers. We have to think of the whole clinical picture, the whole clinical phenotype that the patient has. So of course, if you have triple high, and then you have to look whether maybe the patient has chronic rhinosinusitis, nasal polyps, or some other history, whether it's more of a childhood asthma that he grew up with, or is it allergen induced, is there an eczema, atopic dermatitis. So we look at the whole clinical phenotype, but majority of the time, we have to think about what is actually driving the type 2 inflammation. And majority of the time, this, as I showed you in the data just now, a lot of time it is eosinophilic driven. So despite being all those three that are high, I personally would think that I would try and target the high eosinophils first, monitor and look for any clinical remission, and then if it doesn't work, then only consider switching to Tezi, for example, in Prof. Jackson's study that he shown earlier.
What do you think, Prof. Martha? What's your approach with that?
I totally agree with what you said. I wouldn't add a word. You have to look at the patient as a whole and do not target just one biomarker. The lucky charm in asthma is that we have many biomarkers we can target. We do not have this in COPD, which is a problem. So I would go with what Professor Ernest said. I wouldn't add anything. Totally agree.
Right. I think we still have about 3 minutes. So another questions, probably to Prof. Ernest. So for advice to those working in primary care, so asthma patient on track 1, step 4, but still not well controlled, should we refer those patients for FeNO or we can start LAMA straight away?
Asthma patient on step 4 still not well controlled. I think it's not just refer them for FeNO. Yes, I think if you have that available, why not? These are biomarkers that we do. As I said, we don't treat just a single biomarker. Even the FeNO is high. I think we also need to collect data about eosinophils and look at what is going wrong at that step, whether the patient is adherent, whether he's using the puff correctly, is there any comorbidities. After you have addressed all this, I think there's also a low threshold to start a triple therapy inhaler, as we saw in our case just now. But I guess there's no harm to, if you have the facility available or a place that you can refer. FeNO is a very easy test to perform, depending on, just need to train the patient a little bit, but it's very easy to do. And if you feel that an additional biomarker may change the way that you approach to the patient, then I guess it is helpful. But again, it's not, if you don't have a FeNO, it doesn't mean that you can't treat these patients. As I said, we don't treat the biomarker, we treat the whole clinical phenotype. Yes, it will assist us. For example, if you are trying now, you're thinking about considering biologics and you're thinking about what to use, then having all these biomarkers in place, as well as looking at the patient's comorbidities, may actually help you to choose what is best for the patient.
Okay, next question, please. Severe asthma clinical remission definition varies. So, Prof. Marta, how do you define remission in your setting?
So, very good question. In our setting in Spain, we have our own parallel guideline. Apart from GINA, we have GEMA, we call it like that. And we have a definition that includes symptoms, the absence or near absence of symptoms. We have also exacerbations. It's like a questionnaire. We do a questionnaire. The use of oral corticosteroids and the lung function. We take into account these 4 items, and depending on the points we get in each of the questions, I would say, we define the patient as remission or not. That's why we do it in Spain. It's like as if it were a clinical control questionnaire. We do it like that.
All right. Thank you so much for the answer. And thank you, Prof. Ernest. You may take your seat now. And thank you again, Prof. Marta, for joining us virtually. We hope you enjoy the remainder of the session. So now let's proceed to our next discussion, the Biologic Decision Roundtable, Switch or Stay. It is timely and relevant. So I would like to invite Dr. Noor Ashikin Mohamed and Dr. Jaya Muniswarao to join us on stage.
Let me introduce to you Dr. Noor Ashikin Mohamed. Dr. Noor Ashikin Mohamed is a distinguished internist with a subspecialty in respiratory medicine, practicing in KPJ Ampang Puteri Specialist Hospital. Her expertise lies in managing complex respiratory conditions, including interstitial lung disease. Dr. Noor Ashikin is recognized for her patient-centered approach and exceptional communication skills. Her commitment to advancing medical knowledge is evident through her research publications on allergic rhinitis and rare disease variants.
Right. Please join us when welcoming our panelists.
Thank you very much for the introduction earlier, and I'll start the game. Okay, let's look at my slides. Can we just get it up? Okay, I will be presenting a case from Hospital Pulau Pinang, real case, but of course you're going to hear a bit of flavor from respiratory pharmacists. But I like this statement, when we were discussing about this case, someone from my MDT team just blurted out this statement, and it is just imprinted in my brain. Let's knock off eosinophil. And I will introduce this statement back, looking at our case again. So my case, Miss Unfortunate. The reason why I call her unfortunate, because this is not the most difficult case that came to Hospital Pulau Pinang. It is not that difficult. But why I call her Miss Unfortunate, because why no one referred to us earlier? That's my question, and you will agree with me. A 56 years old female Malay patient with 3 children. right? No issues with drug allergies or food allergies before. That's the pharmacist talking. Okay, I will cut to the chase. Spirometry, obstruction, reversibility, so diagnosis not an issue. Adult onset, pay attention to this, not childhood onset. ACT poor, multiple asthma exacerbation, but you have to look at this, intubated more than 10 times. I don't want to say where she's following up because it's an embarrassment. More than 10 times. But I actually went to the case note and calculated. It's not even near 10 times intubated, it's more than that. Left alone. And she has actually lost hope she lost hope that anyone could help her, so that she just like wander around. I look at the notes. This is 10 years back. I think I was not born that time. 2015, just kidding. Not that young. But I am young. So at one point, omalizumab was given, So I tried to find, is this allergic patient, allergic phenotype, or allergen-driven phenotype? No. It was just one reading IgE was high, then omalizumab given. IgE high doesn't mean your body is deficient of omalizumab. You have to think like that. There's no allergen sensitization to preretinal aeroallergen. So, and I was not very surprised that the treatment did not work at that point. This 10 years back, So, of course, even with biologics, she defaulted because no hope. No one is doing anything. Her asthma is still bad. She's keep on getting intubated. At one point, she just went to one hospital and she got some logistic problem, She just can't travel. Not from very rich family. And good news, she got admitted to Hospital Pulau Pinang. And that point, I think Dr. Leong, our respiratory fellow, she called me. You got to see this patient in the ward. I have this challenge. Can you solve the problem or not? So first thing, I look at her medication history. Over the 20 years, every single inhaler failed. How do you deal with this? MDI cannot. Respimat cannot. Dry powder inhaler cannot. She's just not able to tolerate any type of inhalers. But I got one history, very interesting history. She could tolerate Flutiform. Formoterol, fluticasone is no more in the market now, Malaysian market. She said she could tolerate. So I dig more to the history and I found that actually the problem with her is the post-inhalation cough. Any form of spray that hit at the back of the throat, she starts to cough. She's not able to tolerate anything. But I know Flutiform had like a softer plume, so she could tolerate. And I want to give her a formoterol base because she used to get formoterol and she said it was okay with formoterol. So we put her on MUD, Foster MUD, and we gave her tiotropium. But what I did, supplement with the spacer. So when we put a spacer there, there's no direct hit to the back of the throat. And she could tolerate no more post-inhalation cough. 15 minutes solved the 20 years problem. She gained hope. I think it's not about the science, it's just nobody checked. All right? But I know at this point, even though she will get better, adherence improve, but I think the remodeling is already there. So what I did, I just prepared the budget a bit for her. I know that if she starts to exacerbate, I have to start thinking about biologic. And we couldn't find any other comorbidities like psychiatric, dysfunctional breathing, and all the vaccination were given. As expected, exacerbation, but reduced in numbers. ACT improved a bit, but this is below the minimal clinical important difference. So we had to activate our Penang model for biologic initiation. So what is Penang model? This is our Penang model for biologic initiation. What we do, whenever we have a referral for biologic, we'll go through a checklist. Then we call for our internal MDT meeting. Recently, our cardio team also joined our MDT. If the biologic It's not approved in the MDT. We push the patient to a care we call a patient-centric care. So we go through more vigorous assessment, follow up more rigidly with them. If we approve biologic in the MDT, then we proceed with pre-biologic counseling. This is a mandatory process before we inject, done by pharmacists. The reason why many patients have a lot of misunderstanding about biologic. Some thought you inject today, tomorrow they become superwoman. We have to tell them it takes about 4 to 6 months to even see the effect. And we have to set realistic goals. You cannot promise them everything. Even sometimes I set exacerbation reduction 50% first. Then only I will talk about other things. And we have to talk about all this during the pre-biologic counseling because sometimes they get well, they start to default their inhalers. So these are the problems that we face. This is our SOP for our biologic injection clinic. I define this patient as a hot patient. Why? Not because she's pretty or what. Because she got 2 major biomarkers elevated. FeNO and blood eosinophil. You can see elevated. Forget about IG, it was just mildly elevated, about 200 plus or so. And she's not even an allergic patient. Have you seen this? This looks like a Framingham heart score, right? But it's actually not. This is actually Oxford scale. So this scale actually tells you who are the patients that are going to have frequent exacerbation. The 2 biomarkers came out here is FeNO and blood eosinophil, done by Professor Simon Couliard. And we look at this patient, yes, both of the biomarkers were elevated, right? But we had a dilemma. Which process now is driving the disease? I really agree with Prof. Ernest. People look at all biomarker elevated, right? They say, oh, FeNO high, eosinophil high, IgE high, tezepelumab. I'm not saying something that you won't get your dinner or lunch or your tea break, but we are not treating biomarkers. We are treating patient as a whole. So here the question is, and it's not easy to get tezepelumab immediately in the Ministry of Health setting because it's not in the blue book. You got to apply for the KPK, then you got a lot of other processes to go through. It will take time. Time is something that we did not have with this patient. So I was thinking, what we do? How do we go ahead with this? Yeah, of course, you just said, potong kepala. Go upstream, block it up, easy. But we want to be more evidence-based on this, and we thought, let's just do something, just don't do the shotgun therapy, you know. Let's look at this. This is the algorithm to select, published by Professor Simon Couliard as well. And we look at, okay, how do I decide whether it's eosinophil predominant type 2 asthma or FeNO dominant type 2 asthma? So is it driven by IL-5 or is it driven by IL-13? Because FeNO actually a surrogate to measure IL-13, interleukin-13. So the first thing we look, is it the onset, the age of onset, right? And this is a late onset asthma, so the green tick went there. Less allergy, the tick went there. Airway hyperresponsiveness, we were not able to detect, so I just put a question mark. Less atopy, but there's no chronic rhinosinusitis with nasal polyp and all that, and this side also, we don't have anything. And whether the eosinophil signal is more than FeNO signal, or the FeNO signal is more than eosinophil signal, we're not able to decide. But one thing, we were very clear, she responds to OCS very well, because even during intubation, they give the steroid, they could extubate her very well. Even she come to emergency department like 2 to 3 days of oral corticosteroid, she responds very well. So 4 ticks here, and we thought this should be the eosinophilic predominant type 2 asthma. The selection, while Simon Couliard did say that you can choose bendalizumab, you can choose dupilumab, you can choose tezepelumab, by looking at the cost, and patient got logistic problem, because bendalizumab, after the 3 loading dose for every 4 weeks, you can give 30 milligram for every 8 weeks. So, sounded very interesting, sounded like a very good option for this patient. Thank God we managed to secure the funds. She got no option, no JPA. So this is where the MDA, during the MDT point, somebody said, let's knock off the eosinophil and try. and let's see what's happening. And that's what exactly we did. Pre-biologic counseling was given, and usually after we have injected the patient, we have like a 1 hour observation in the clinic for the first injection, then subsequent injection we usually observe for 30 minutes. And this is our pre-biologics counseling checklist that we use in Hospital Pulau Pinang, validated by my Sifu, Prof. Mariko from Singapore GH. We even talk about the JPA patient, because sometimes JPA patient, if you don't talk about their funding, after they have finished the injection, they will appear in front of the clinic, say, where is my injection? I did not receive it. And then we realize they actually did not even renew their application. What we can do? Because nobody have educated them. And we also give a continuous patient monitoring education. For this patient, because she had trouble coming to hospital, we gave her some virtual counseling as well to make sure that everything goes well. This is our biologic injection monitoring sheet that every time patient comes for injection, we will enter the dates and monitor. So the moment patient play up a bit with the injection, we don't have to wait. One dose they miss, we start straight away give the patient a call and try to make sure that what's going on. Our clinic staff usually enters the date after they have injected the patient. All right, so now she's in remission. I just want to tell something very quickly. After we have started benralizumab, patient doing well, even remission, we don't just do the CTS. You know what is CTS? Canadian Thoracic Society, no. Continue the same. Even though patient doing well, we have to look at future direction. We keep an eye. So last week, Bendrax study was published. As expected, the real-world evidence with benralizumab is about 78% risk reduction in asthma exacerbation, right? But what they have highlighted, something very interesting, because we know the moment you give benralizumab, your blood eosinophil is going to go zero. So it's while the patient on biologic and they experience exacerbation, do you think eosinophils are the driver for the exacerbation? Based on Bendrax study, no. So they said, since the eosinophils are zero, it's unlikely eosinophilic inflammation. And what they have proposed, you look at airway neutrophilia, you look at viral pathogens, altered of sputum microbiome point to infection as the most prominent causes of exacerbation. Why they have discussed about this? Because they are questioning, if patient on benralizumab got an attack, got an acute exacerbation of asthma, giving prednisolone, is it going to help this patient? Of course, our threshold to prescribe prednisolone is very low. Even you've seen the global data as well. So this is towards personalized medicine approach. And Prof. Sanjay Ramakrishnan from Australia published this algorithm. What you do when your biologics patient develop an exacerbation. So nice algorithm, I thought it's very nice to do this, is towards personalized approach, personalized medicine approach. All right, so since we are looking at good improvement in our patient, and we don't want to do CTS, so what else we can do? We still monitor the patient for IL-13 escape, because we know benralizumab, even though it's very good at knocking off eosinophil, it does very little to interleukin-13. That means you do not expect the FeNO to drop. The FeNO may drop due to many reasons. Even improved adherence of inhaled corticosteroid may drop the FeNO. So what we do, we still watch for anti-IL-13 escape. That means we look at, sorry, not anti, it's IL-13 escape. We look for elevation of FeNO. If patient is clinically deteriorated, you look for this. If required, we may switch to tezepelumab or dupilumab, but you have to be careful because the baseline eosinophil is high. So dupilumab, it tends to push up the eosinophils, but that's not a big deal. We have a lot of experience managing it. And this is the exact statement in American College of Chest Physicians' latest CPG on biologic management in severe asthma. And I do believe we're really changing lives here. Thank you very much for listening.
All right, thank you very much, Dr. Jaya. Please remain on stage. Next, I would like to invite Dr. Nora Shikin to share with us her experience on how to switch the biologics in her patient.
Good evening. Assalamualaikum warahmatullahi wabarakatuh. Thank you, AZ, for having me here today, and thank you for staying until this hour. Can we have the slide on, please? Okay, so my turn to talk about today during our roundtable discussion is basically to look on the whether we want to switch or whether we want to stay in particular patient I'm going to present. Basically, we're talking about overcoming biologic failure in this particular scenario with patients with severe asthma as well as chronic rhinosinusitis with nasal polyp. So we'll talk about the rationale and what is the strategy for switching from, in this particular patient, from Fasenra to tezepelumab. So a bit of outline, we'll talk about the case study and a bit of discussion and conclusion. So I have a patient, 41-year-old man, who's a marketing executive. He's a lifelong non-smoker. He's married with 3 children. Family history include his mother and his younger sister having asthma. His BMI was normal. He has no known drug allergy, but he's allergic to seafood and mites, giving his allergic rhinitis symptoms as well as asthma. Coming to the baseline diagnosis, he was diagnosed at 21 years old formally. He did not report any symptoms during childhood, but at 21 years old, he was formally diagnosed with spirometry. And initially he was stable, but becoming more and more poorly controlled since 2019 at the age of 32. He had multiple asthma exacerbations, and he was intubated twice in ICU. His baseline ACT was poorly controlled around 15 to 18, precipitated frequently by cold weather and post-nasal drip because his allergic rhinitis is not controlled. His baseline FEV1 that time was 56%, which was still reversible post-bronchodilator. Of course, for severe asthma patients, we have to do the workup for completion. So his IgE was high, around 900. That was back in 2020. His specific IgE was positive for mites. And his eosinophil was on the normal side, but slightly higher normal, around 200 to 280 cells. There was no FeNO in the center at the time, back in 2020. He was also seen by our ENT colleagues, and he had done FAST for his nasal polyps, and that was done back in 2017. Frequent nasal congestion was still a problem. He had a recurrent sinusitis attacks with facial pains as well as anosmia. He was on regular nasal spray, decongestant, antihistamine, you name it, under ENT was all complete with a recurrent OCS burst by ENT. All right, so he was on, initially he was on ICS Labamart, and then he was switched to another ICS Labamart for the sake of thinking could it small airway disease at that point under other physicians. He was added on Tayo for triple therapy. That was still loose triple therapy, but he was still requiring naps in the GP setting as well as going to ED in and out, despite being compliant and having a good technique for these 2 inhalers. He was admitted to ICU for severe ARBA, but thankfully that time he was not intubated, but he was on high flow mask. He was changed at the time to SITT with Enerzair. His ACT was still poor during follow-up, about 18 to 19. He was considered for the slit therapy, but unfortunately FEV1 does not allow it, so he was literally contraindicated for slit. And he was considered for subcutaneous omalizumab. At that point, it was still in 2021, so it took about 6 months to get the approval. We kept on pursuing the insurance to get the omalizumab at that time, and he managed to get it after 6 months. So now coming to 2023, he was still on SITT, he was compliant, still frequent admissions despite not being intubated, but he was still admitted frequently almost every month. His MMRC then was 2. The peak flow in clinic was barely making it to 250. He was started on regular OCS 5 milligrams daily with a burst in between from the attacks. And at a point when the when the Xolair was approved, he was given it few times, 3 times, and then he defaulted. unfortunately. So nothing happened after a few months, and then he was admitted again to House Hospital, and that time he developed pneumonia with Klebsiella and have some candida in the sputum. So the oral prednisolone was decided to be stopped. The reason why he was defaulted was because of change in work, and he did not have the insurance at that point in between. So he still continued on the fixed triple dose therapy for the inhaler, very bad sinus symptoms, and the ENT did another FAST this time back in 2024. So our ENT colleague referred back to us to reinitiate the omalizumab, thinking that he was improved on Xolair that time. So he was still on daily naps, unfortunately, and now he upgraded himself buying a new naps at home using daily Ventolin. His ACT down to 14, and eosinophil now increased. From the previous cases that's been presented, eosinophil can actually be labile, and at that point in 2025, his eosinophil elevated to 400 to 590 during the follow-up, and this happened after surgery, the second surgery. So he was counseled for benralizumab, which took 2 months approval. So I think at this point, the biologics has become more and more familiarized by many stakeholders. So it took less time to be approved this time. So it was started in August 2025. So what happened was he managed to get the 3 loading dose, and then after the 4th dose, he said that he had no significant improvement at all. At that point, we look at the eosinophils during the follow-ups. Guess what? The eosinophil was 0 after the first dose. So the patient did not feel better, the ACT around 19, but the FeNO was remain elevated at 39 ppb. So it's affecting his quality of life because of both the asthma as well as the sinus symptoms with anosmia and postnasal drip. So then we spoke to each other. I contacted our ENT surgeon. He was deemed to be very high risk to go for another surgery. From the CT scan that they did, there was still another polyp, and that polyp clearly was not able to be resectable because it's quite near the basal skull. So the eosinophil remains 0 throughout. The FeNO was ranging around 20 to 30. IgE was more than 1,000. And the FEV1 with the triple therapy and OCS regular 5 milligrams and Fasenra, the FEV1 was 66%. So he was counseled for TASI. He was started on TASI back in April and May. Yesterday he came for follow-up just for his hypertension tablet. But I was asking her, how is he doing? But he said, oh, I'm not improved. So I said, how is it not improved? And then he said, because he feels that the nasal discharge was still there. And I said, how much nebulizer are you using? He said, no nebulizers this last 1 month. So that's how, you tease out the history from the patient. Patient can tell you anything, but you have to actually clarify with them. So for me, no nebulizer for the last 1 month is a major game changer, and no OCS burst since the last month. So he was only on 5 milligrams and no attacks in between. And his peak flow was actually increased to 380. And the ENT called me yesterday, the polyp was actually regressed. No polyp at all during the nasoendoscopy. So this is something really major. And the sense of smell was actually partially improved. And this was only after 2 doses of TASI. So I think we did it. All right. So again, I think we discussed this earlier on, the blood eosinophils. We're not treating the biomarkers again. So for this particular case that I presented, the blood eosinophil was 0, but the patient did not improve. So we look at the other biomarker, what could be the possible reason why the patient is not improved. It's basically localized epithelial inflammations. So again, there are unmet clinical need for these for the patients with 2 different diseases, the lower and the upper airways. So the clinical insight is that we know that the peripheral eosinophil ablations is not equal to the tissue level control. So that's how when we decide to switch, so the mechanism of switch is actually moving upstream to the epithelial cascade, and then basically from the epithelial triggers that cause the alarmin, and that's when we actually block the alarmins to actually improve these 3 things downstream. So the clinical evidence actually is very clear to show that from this particular study and rapid smell recovery in terms of targeting the olfaction, polyp regression, and steroid weaning. For this, for my patient, we haven't stopped the steroid because it was still too early, and then we actually plan to wean the steroid later. So the practical approach, I think people talk about this earlier on, how do you actually reduce or weaning the steroid for those patients. And then for this particular patient, we have secured him a 6-month TASI approval. So that's when we are going to, taper the steroid accordingly. Last but not least, I think we're targeting the pheno, and then we have to actually get the symptomatic control, because that's how patients perceive their improvement, not the biomarker per se. But for us clinicians, we have to look overall patient as a whole. So in summary, I think you've seen this many times from Prof. Jackson and also Prof. Po. So basically, when we block the TSLP, so it's actually blocking the downstream. So until now, the biologic has targeted the downstream mediators, which leads to residual inflammation, and which may leave the residual inflammations unaddressed. So I think this is basically repetitions to show you how much of this cascade can be reactivated by just having the TSLP. So tezepelumab blocks the TSLP and reduce all these cascade allergic inflammations, eosinophil inflammations, and structural effects of T2, as well as the non-T2 inflammations. So the broad effect on the downstream mediator of airway inflammations, which improve the patient's symptoms and also lung function. So with that, I thank you.
All right, thank you so much, Dr. Jaya and also Dr. Nur Ashikin, for sharing with us very interesting, as well as it not only tells us that how the patient progress, how the patient respond, but it also shows us that the chronological order on how to choose and switch your biologic based on the event that patient experience. So that concludes our insightful severe asthma session for an enriching discussion on this important topic. So we will now take a short break and reconvene at Okay, 6:38. Sorry, I need to be very precise. Time is money. So 6:38 p.m. for our next session on severe asthma. We will see you shortly. But before that, please, dear delegates, we would like to kindly request everyone to take a moment to scan the QR code on the screen again. So to complete a short post-event survey for COPD and severe asthma session. Thank you. Expertise in stereotactic radiosurgery and radiotherapy, stereotactic body radiotherapy, and advanced techniques including IMRT, IGRT, and VMAT. She manages systemic therapies across immunotherapy, targeted therapy, chemotherapy, and hormonal therapy. She also provides brachytherapy, pain, and supportive care. Her clinical focus spans breast, lung, nasopharyngeal, head and neck, brain, gynecological, gastrointestinal, and genitourinary cancers. She is active in national and international oncology communities, has additional training in gamma knife radiosurgery and thoracic oncology. She also contributes to education and public awareness through publications and media. Please join us in welcoming them to the stage. The floor is yours, Prof. Ernest.
Thank you, AstraZeneca, for again inviting me to moderate this event. And I'm here with two esteemed experts and speakers. So thank you all for staying at this hour. I know we are standing between you and dinner at Latest Recipes. I think all of you can't wait to enjoy a buffet dinner after a long day of talk. So I'm going to set the platform here first, the stage here. We are speaking to a lot of primary physicians, primary care, family medicine specialists, some medical officers, respiratory medical officers and trainees. And of course, we also have our respiratory physicians. So we want to keep the talk quite at a good level so that we don't lose our audience. It's also at this hour of the day where everybody is hungry and tired. So we want to keep things simple. so that all of us can understand. It is also a very exciting time because this is the first time in the Brief Summit that we have an oncology talk. We have never had it in the past. Over the previous years, this is the first time that lung cancer is getting an attention in a respiratory summit. So we want to thank AstraZeneca again for including this session because lung cancer is getting more and more important by the day. And it's also a very exciting time to diagnose and treat lung cancer because these days we are able to diagnose and treat lung cancer at a much earlier stage. Okay, we have seen patients that come in only when they have symptoms and they are diagnosed to have stage 4 up front. But these days, we are seeing more stage 1, stage 2, and even stage 3 patients. And so we want to really lay the overview of treating this group of patients and how we can transform their outcome to give them better survival. Okay, so that is the reason for our talk today, and we hope that in this next 45 minutes or so, we don't lose you. We will keep you interested, and you will know what to do when you actually encounter a patient with lung cancer. Okay, so we're going to start the floor with some questions. You all can have your mics with you. I think I will ask both of you, actually also myself also. When we see a potentially resectable non-small cell lung cancer patient that is referred to, both of you, I'm sure they come to SIVA a lot straight away. Probably Mafwa not so much because they would have the diagnosis, but again, you will still have to deal with that. What do you do? I mean, who do you need to rope in other people, or do you own the patient and then you decide what happens to the patient?
Okay, maybe I will start. So for us in University Malaya, we have a very strong MDT board. So most of the time, these patients actually come to us through an MDT. It'll be presented and then discussed. Unless it's a very straightforward, single isolated lesion with no any other nodal involvement and the size is small, then my chest physicians will straight away refer directly to me. If not, anyone stage 1B and above will be brought straight into the MDT. And then from the MDT, then we will decide on suitability on their pathway of treatment. Majority of them still go for upfront surgery. Of course, with the advent of the newer trials like Keynote and Checkmate, things may change in coming years, but due to funding related issues, for those resectable ones and they're operable, they go straight for surgery as of now.
Okay, so Prof. Siva has said that if a patient is referred to him directly for stage 1 or 2, and it's quite straightforward, he may not necessarily need to bring it to the MDT. MDT stands for Multidisciplinary Tumor Board, okay? And he will probably just arrange surgery up front. What about you, Mafwa? If someone refers you a stage 1 and 2, or even a stage 3 cancer patient, what do you do?
Okay, I think we can normally see patients, predominantly it used to be surgical, they go straight to surgery. But then nowadays we have patients who are trying to defer surgery. So we do see patients with early stages, but trying to see whether there's other options of surgery. That's number one. Number two, there are also patients that are borderline resectable or not quite sure. So I think rather than one person owns the journey, I think we're seeing a change that now is no longer a linear journey. Previously it used to be diagnosis, surgical referral, surgery, and then see what kind of treatment they need after surgery. But I think now, as you mentioned before, it has become a team effort. And even in cases that are not quite resectable, we do still discuss at MDT level. So teamwork is very important.
Yeah, but it is quite a challenge, isn't it? In the university setting, I think, or even in some major government hospitals, there is a lung tumor board or a MDT. But in private hospitals, now that you are in SGMC, how do you manage this sort of dynamics?
Right. Some patients tend to actually come to both of us. Actually, they go to surgeon, and the surgeon will then refer on the same day to see me, to see what are the options for this patient. And even though we don't have a set MDT like in the university setting or the Ministry of Health setting, I think our MDTs run in corridors and also clinic halls. So it is still a discussion point of view. Patients who are, again, as Prof. Siva said, very straightforward, stage 1, no nodal metastasis, then they tend to go straight to surgery.
So MDT doesn't really need to be like a fixed time, you need to get 3 or 4 people. It can be just a conversation over I think some centers even do it over a WhatsApp, I heard recently. Okay, but no, we try and meet and at least have a proper conversation involving the oncology, the respiratory physician, and sometimes even the pathologists and radiologists and the surgeons, of course. So let's move on. From different specialty standpoints, I think this one I'll address it to Prof. Siva to address very quickly, because I think in your slides also you will probably talk about it as well. What defines tumor resectability?
So tumor resectability is very much dependent on the anatomical location of the tumor. What guides us for this is usually the CT scan and the PET scan. So what we deem as safe resection will always be trying to spare as much parenchyma as possible and do the necessary removal. The gold standard operation will always be lobectomy for tumors more than 2 centimeters. There are some trials supporting less than 2 centimeters to do a segmentectomy or a wedge resection. But resectability again comes down back again to the surgeon or the person who's doing the scan, and to see how competent one is to do the extensive resection. Some may just stop at lobectomy, some may can continue to do bilobectomy, or some may continue to do a sleeve resection or a double sleeve resection, and in worst case scenarios, even a pneumonectomy if it's a young patient fit with good lung reserve. So all this again goes back to our basic, where you need to understand the anatomy, the resection margin line, where you need to aim for an R0 resection, and interpreting the CT scan and PET scan together with this.
So a lot of it also I hear is also based on the surgeon's skills, and of course the staging of the tumor, the anatomical position and all. And Marfa, do you have anything that would you discuss with your surgeons and ask them whether, or would you, based on PET scans, decide that the tumor most likely can be resected, or do you discuss with even your your respiratory physician colleagues?
I think we do that in a way, because sometimes it's not just about trying to remove the tumor. I think nowadays we're talking about how is best the patient to be cured actually. Is this a patient who can just have surgical resection? Or is this a patient that we know is very highly to relapse? And that comes the nodal staging. And then for that, normally I need the respiratory physician and also the cardiothoracic.
So a lot of people have the opinion that after a surgery, you are completely cured of the lung cancer. Once you had the surgery done, it's done. You don't have to think about cancer anymore, which is not very true in most of the cases, because as we know now, there are micrometastases and the relapse rates recurrent rates are very, very high. So with that, I will move on to the next question. How is a particular patient selected? I think this is quite repetitive. We have done this many, many times, but I want to give the floor to Prof. Siva. If you want to sit here, it's fine as well. If you want to stand, also fine, to actually go through some slides with us. Do you want to sit or you want to?
It's okay, I'll stand, no problem. Okay, this is just a quick run through on how we decide who is resectable and how do we decide it. Okay, just a quick outline a little bit about the talk. Okay, this is just more on the technicality, how we evolved from TNM 8th edition into TNM 9th edition with the breakdown of the lymph nodes in N2, coming to N2A and N2B, and also on the M1C to M1C1 and C2. Now, why this is important? Because this actually is the determining factor on how aggressive we can move on. The nodal state in the mediastinum is very important. Multi-station nodes, we usually tend to go for neoadjuvant treatment. Single station with a resectable single lesion in the lobe, we may go for upfront surgery. Just a brief outline about how the lung parenchyma looks like. 3 lobes on the right, 2 lobes on the left, 19 segments in total. That gives us a count also of how suitable a patient can go for surgery based on their remaining lung reserve with the existing lung function, FEV1 and DLCO. So resectability, as I mentioned earlier, it's based on CT scan. It appears for safe resection, and that's a surgeon's decision. That's the anatomy of it. Operability, on the other hand, is the patient's premorbid condition that allows patient to undergo GA safely and to have adequate lung reserve, and that's the physiology of the patient. So you've got one component, the anatomy, and the other component, the physiology. So a patient who is deemed suitable or fit for surgery has to satisfy both these components, resectability and operability. So some examples of the scans cases that I've operated in the past. The one on the far left is a straightforward left upper lobe tumor, close to the fissure, but it is resectable. The one on the middle is a very big left upper lobe tumor, very close to the arch of aorta, probably invading the left recurrent laryngeal nerve and also the phrenic nerve, borderline resectability, and this is a straightforward right upper lobe tumor, no questions, we take it straight for surgery, right? So in resectable stages, usually we go on with stage 1 or stage 1, stage 2A, 2B, 3A, and in stage 3B, we do consider T4 and 2A. The rest of it, generally, we will tend to take it down the neoadjuvant pathway, and then we decide from there. But even now, with the advance of the newer immunotherapy trials, stage 1B till 3A can be considered for neoadjuvant. And at the same time, with the latest out on Keynote 671, stage 2 and stage 3 are going for upfront chemo-immuno followed by surgery and then by adjuvant immuno. Operability-wise, we have got few guidelines to help us. Among the commonest is the BTS guidelines, it's tripartite risk assessment. We looked at post-op cardiac event, perioperative mortality using Thoraco score, and post-operative dyspnea risk, where we calculate the predictive post-op FEV1 and DLCO using the lung segments, and the remaining that we accept safe has to be more than 40%. What are the evidence we have for surgery in lung cancer? Lobectomy is the gold standard operation that's across stages 1 to 3B, and that's backed by the Lung Cancer Study Group. It was the first randomized control trial for a surgical cohort of patients in lung cancer treatment, and it was done in 1995. And in that, it states lobectomy is far more superior than wedge, where wedge has got a 3 times higher recurrence rate, followed by segmentectomy 2.4 times. These are other papers that came along the way where they wanted to do lesser resection, segmentectomy, comparing against lobectomy. And the most recent trials out for tumor less than 2 centimeter with no lymph node involvement is the JCOG 0802, the Japanese group, and the CalGB 140503, done in the States, which states tumor less than 2 cm and mediastinal lymph nodes are negative and hilar nodes are negative. They are safe to undergo a lesser resection and lobectomy, which is either a segmentectomy or a sublobar resection, which is called wedge. Now, what do we have in Malaysia in terms of treating for this? In Malaysia, we came up with our national consensus last year, which is a surgical consensus for early stage resectable non-small cell lung cancer. So in it, we state that patients who have been diagnosed has to go to treatment within 4 to 6 weeks. Everyone needs a PET CT scan, and all stage 2 and above will need an MRI. So this also will decide on us deciding them for resectability. And patients who are for neoadjuvant and peri-op treatment, stage 3 onwards are discussed in the MDT. For resectable stage 2, it's reasonable to take them down the MDT to discuss also for neoadjuvant. However, radiotherapy shouldn't be a treatment modality for resectable cases. Right? And adjuvant treatment, all stage 1B to 3B are considered for adjuvant. If you look in the past, we have got a LIST meta-analysis that states any tumor more than 4 centimeters and lymph node positive goes for chemotherapy. It gives a 5-year, 5% survival advantage. However, with the newer advance of immunotherapy, combining with chemo or targeted therapy, that has changed the paradigm shift in how we treat. So there are many trials to support that. And what we want in surgery, we want an R0 resection. You cannot leave cancer behind. If you're going to leave cancer behind, then you shouldn't commit surgery, because there are other treatment modalities where we can use for patients with lung cancer nowadays to treat them. What approaches we have? The standard old-fashioned open thoracotomy. We have got VETs, 3 ports or 2 ports. What we practice in University Malaya is single port VETs, uniportal VETs. We've also got uniportal subxiphoid VETs. Robotic VETs is coming around and developing slowly. And what we offer patients are lobectomy, sleeve, pneumonectomy, or segmentectomy. It's just an intraoperative picture of a VETS, right lower lobectomy. This is how we position ourselves in the OR. It's just a short video. Don't know I can play or not. Yeah. Okay, this is how the chest looks on the inside. And this is how we do our resection. And this is a VETS, uniportal VETS, right upper lobectomy. Right. And then this is a segmentectomy. We're doing a S6 segmentectomy for a left lower lobe. Right, you can see that's the segmental branch, and that's how we dissect in the hilum. We use some specialized energy device, and that's how the segment is then isolated, and we remove it. Okay, and this is how we remove using the stapler, which does the resection to remove that particular segment, and then the disease area is removed. And this is how we isolate the segment by testing the lung. All right, at the end of this is the wound that we have. Okay, the wound is about 1.5 to 2 centimeters. So current surgical approaches trials, we have got the Violet trial, which was presented by Eric Lim in 2019. It's a multi-center trial comparing VETS versus open. In this trial, it shows that VETS is not inferior and does not compromise in early oncological outcome compared to open surgery. Patients stay 1 day lesser and they have got lesser pain. Now, most of the major thoracic centers worldwide, they do VETS as a standard of care. Irrespective, it is 3-port, 2-port, or 1-port. In PPUM, as I mentioned earlier, we do 1-port. So just to share some cases that we have done in the past. So this is a 48-year-old lady diagnosed with a left upper lobe lesion, incidentally, during a routine health checkup. She had a CT scan and followed on by a staging PET CT and a CT-guided biopsy. So you can see she's got a lymph node in the mediastinum, and also the left upper lobe tumor, which is very brightly lighting up there. So biopsy confirmed it is adenocarcinoma, EGFR positive. PET scan shows a 2 by 3.5 cm left upper lobe tumor, positive station 5 lymph nodes, MRI brain normal. So she was a stage 3A, good lung function. MDT, we took her down that pathway, resection was his neoadjuvant. I felt I could do a surgical resection safely, so we took her in for a uniportal VETS, left upper lobectomy, and mediastinal lymph node clearance because she had a single station N2A node in station 5. This was the station 5 lymph node. This is the view on complete removal of the tumor on the VETS view, and this is the specimen itself. And the pathology report came back because I tend to remove all the lymph nodes as much as possible. She also had a station 6 lymph node positive, so she's actually an N2B. So, and she also had spread through airspace, but all the other lymph nodes were negative. MDT discussion, adjuvant osimertinib, PET scan 1 year post-treatment, still no disease recurrence. Another case, a 62-year-old male, chronic cough for 6 months, investigated and found to have a right lower lobe mass, CT and PET done. This is the lesion, and she's got a very bulky hilum. You can see there's multiple lymph nodes there, and also the right lower lobe tumor. Okay, this is another view. Right, so the tumor on PET scan, station 7, 9, and 10 lymph nodes were positive, with a right lower lobe mass which was crossing the fissure, about 1.5 by 2.2 cm. Biopsy, adeno-CAA, EGFR negative. So this was I would say, a borderline resectable case, took down the MDT pathway. We decided to treat the patient first with pembrolizumab using the Keynote 671 protocol. So initially it was a T1C, N2B, M0. Then post-treatment with Keynote 671 with pembrolizumab for 4 months, scan was done, everything disappeared. Quite an amazing response. So I took the patient back in then for right uniportal VETS lower lobectomy and mediastinal lymph nodes clearance. And this is the view on the inside. You can see with immunotherapy how fused the lung lobes are and how sticky the hilum becomes. Challenging surgery, but doable. Right? So post-op histology, all lymph nodes were negative. The primary tumor came back, has adenocarcinoma in situ, and now the staging is YPTIS and not M0. Patient is recovering well 6 months post-op and on adjuvant therapy. So in summary, all stages of lung cancer treatment, you need an MDT. VETS is the standard of care in our surgical resection nowadays. Reflex testing is mandatory because it gives, it's better in the pre-op during the initial biopsy itself because it gives us a good idea on the treatment pathway for the patient, and neoadjuvant cases that I shared earlier can be technically challenging, and you need proper planning in order to do it. With that, thank you.
Thank you, Siva, for the very good overview of surgery. So just for the benefit of our audience, also some of the more younger doctors, the perioperative treatment involves giving treatment before and after surgery. So it constitutes neoadjuvant treatment, which means you give either chemo or immunotherapy before surgery, then patient goes for surgery, and then they are followed by adjuvant treatment, adjuvant chemo or immunotherapy. So when you put this all into together, the neoadjuvant, the surgery, and the adjuvant treatment, these becomes the perioperative approach to a patient with early stage lung cancer. So as you can see in Prof. Siva's talk, surgery is rarely a standalone decision. He had to engage the oncologist to decide on whether to give a neoadjuvant or even a perioperative approach in terms of treatment. So I would now pass the time over to Dr. Mafua, who will give us a brief overview of the perioperative IO or the immuno-oncology drugs in the early stage setting.
Thank you, Ernest. I can still remember your stare. Keep it simple. Okay. Sorry, can I get the... Right. Okay, so I can start by saying that lung cancer is nowadays a very different story. Okay, previously, I think about maybe 10 years ago in Selayang, I remember there was a stage 4 lung cancer patient, and we just walked past him every day because stage 4. But Pakcik was very well. He was eating, he has no cough, but he's stage 4. Okay, because I think last time we think stage 4 cancers are at the end of the world. Yeah. But nowadays, stage 4, even stage 4 lung cancers, they can live for a very long time. They have very different treatment profiles. Okay, so if stage 4 can do better nowadays, let alone the early stages. So this is what I'm trying to present today. So just an overview. Okay, so Prof. Siva has kindly showed us all the stages and showed us that in patients who are resectable, surgery is still central. Okay, surgery is a very important intervention in assuring cure in patients with lung cancer. But the problem with lung cancer is not like any other cancers. Their relapse rates is very high. And 80% or 90% of patients who present with lung cancer, they tend to have distant metastasis. So it is a disease that is very heavily micrometastasis disease. Yeah? So that's why surgery alone might not be feasible in patients with lung cancer. So if you look through the strategies, in patients with early stages, but you can't operate, so the medically inoperable early stage, you can go for radiotherapy. So radiotherapy is a local therapy, just like surgery. Whatever you shine, that's the only area that's affected. Okay? In patients, as Prof. Siva mentioned, the stage 3 with EGFR. So what is EGFR and ALK? These are mutations that we see in lung cancer. In our region, EGFR status is very high. The never smokers, the female. So these are the group of patients that we 50% will see in our population. And when they are EGFR positive, they can have EGFR targeted therapies, which is oral tablets that will reduce the need for chemotherapy or any other intense therapy. So these patients, they actually should go for surgery followed by targeted therapy. So we are actually looking at the resectable stage 2 and 3, but non-mutation. So not available to give targeted therapy or tablet therapy after surgery. So this is the group that we want to talk about. Okay, so I mentioned before in the beginning that nowadays our pathway is never linear. It's not just a one linear pathway. We don't see patients at the end after surgery anymore, but we are actually seeing patients early on, because the problem with this pathway is that we get high relapse rates. Okay, and you see even in the early stages, even in the stage 1 and 2, you see about 20% patient relapsing. And if a patient has stage 3A, the chance of relapse is almost as high as 50%. Okay, so now the idea is that we want to discuss cases upfront, we want to have a strategy to reduce not just the bulk of disease, but to ensure that we have ongoing suppression. Okay? When we have ongoing suppression, when we tackle systemic disease that we can't see on scan, then we ensure better survival. Okay? So what is the role of immunotherapy? Okay, so chemotherapy, I think everyone knows chemotherapy, very bad side effects, but it's very good at attacking very rapidly proliferating cells. So chemo works very well for cancer cells because they are very rapidly growing. But then chemo, you can't actually give it for a long time, unlike targeted therapy, okay, because they have toxicity. So this is where immunotherapy comes in. If you think about it, chemo is like a bomb, okay? So you bomb an area, so everything will be affected. But the good cells will recover. What immunotherapy does is actually training your army, yeah? So it's training your army to then know your enemy. And then the duration of response is longer. So it's more sustainable because you have better army at killing cancer cells, okay? So how does it work? Okay, so this is one of the immunotherapy called durvalumab. So what happens is that cancer cells, they have like an invisible cloak that makes it invisible for the immune system to target. So what immunotherapy does is that it removes that invisible cloak, making it more apparent for the immune system to target the cells. Yeah, so that's how immunotherapy works in simple form. I'm trying to follow what Prof. Ernest is saying, okay? So, why do we give neoadjuvant? Because we want to start killing the micrometastasis early. So we're treating the whatever is visible and whatever is invisible up front, okay? And then after surgery, we want to sustain that effect. So that's why it's the peri-operative approach. Neoadjuvant before the main treatment and adjuvant after the main treatment. That's the whole peri-operative strategies. Yeah? Okay, so don't worry too much about this, but just to show, now we are looking at many new evidences of peri-operative strategy. Okay, so it started with Checkmate 816. They give chemotherapy IO just before surgery, didn't have anything after that, and it works very well. Okay, oncologists are very happy looking at PCR, complete response. So when you take the specimen of the surgery and you can't see any tumor, so we like that. Okay, so that's what we look for in neoadjuvant strategies. But the rest of the trials are looking at peri-operative, meaning that you give before surgery, do surgery, and then after that carry on with adjuvant immunotherapy. And the results are so much better compared to surgery alone. Okay, so just to highlight, this is the first study that shows if you give chemo immuno before surgery, just 3 cycles, and then followed by surgery, you see the PCR rate is remarkably better with chemo immunotherapy. Okay, and in the past, we used to do surgery and then chemo, but a lot of patients after surgery, after they have recovered, they felt that Prof. Siva has saved my life, and then now the oncologists want to actually destroy my life by giving chemo. Okay, so it's so much harder to sell chemo after surgery. But with neoadjuvant, they know in a way that we need to give chemo so that we can shrink the tumor so that surgery becomes more feasible. So if you look at it, the changes between those patients who had chemo and immuno before surgery, the PCR rate, complete response is about 24% versus only 2% if you don't add immuno to the combination before surgery. Okay, so very remarkable. So then we move on, because of that success, we are moving on into giving peri-operative. So you can have many combination of chemo IO. So in this agent study, we use durvalumab as the IO, and then chemotherapy for 4 cycles, and they had surgery, and then they then go on with adjuvant immunotherapy for a total of 1 year. Okay, so if you see, they have included all types of, it's very balanced between the 2 groups. Okay, they included all stage 2, 3A, and 3B, even the borderline. And then if you see, even adding, because sometimes we worry that we want the patient to have chemo and immuno, but we worry whether we will make the surgery difficult for the surgeon. Okay, but you see, in this case, majority of the patients still actually go ahead with surgery. Yeah, so there's no issues with resectability. Yeah. And in terms of the surgical complication, it's actually more or less the same within the group that had chemo-immuno and those who didn't have any. Yeah? So it's basically on trial, it's rather safe for the surgery. Okay, so does it work when we give chemo and immuno? So you look at the PCR rate, again, you can see the difference between the group that had neoadjuvant, perioperative chemo IO compared to those who had placebo. Okay? So of course, when we see a high PCR rate, that basically translates into higher survival. Okay, and we also for oncologists, we like survival curves. So if you see between the two curves, it's splitting away, it means it's good intervention, meaning that the effect of chemo-immuno is sustained. So basically you get reduction of death, reduction of recurrence, and reduction of progression compared to when you do not give chemo-immuno with surgery. You don't combine that with perioperative strategy. Okay? So you can see regardless of what stage, regardless of the age, smoking history, everything is favoring perioperative strategy. And for those who knows about PD-L1, even regardless of PD-L1 status, it's predictive for immunotherapy response in stage 4. In the early stages, it doesn't matter. Regardless of PD-L1, chemo-immuno still shows benefit when we give it during the perioperative strategies. Okay, so again, is it safe? Generally, it doesn't really scream any safety signal. The common side effects is still more or less the same even without the chemo-immuno. What other basically toxicity that we're most worried about with immunotherapy is pneumonitis. And if you see in terms of pneumonitis of any grade, it's only about 4.5% compared to 3.4% in the placebo arm. So it's not, the toxicity for pneumonitis is not extremely higher in those who have perioperative strategies. So basically in conclusion, when you give perioperative strategies, it increases the chance of survival by increases the chance of PCR. It's rather safe for surgery, and it doesn't increase the risk of toxicity. Okay, so this is another study. It's similar, but we use pembrolizumab. This is Keynote 671. So it's just changing the backbone of the IO. Just now, agent looks into using the nivolumab. Keynote 67 used pembrolizumab, and the efficacy is the same between all the trials. So basically, we're not supposed to compare cross trials, but I wanted to show that basically, regardless of what regime that you use, what immunotherapy you use, you see a comparable or a consistent results that it will increase your PCR rate and also reduce the reduction of risk of progression or recurrence when you combine when you actually get patient to have perioperative chemo IO. Okay, so we know that it works. The next part is does it work in real life? Okay, so MDT Bridge is actually looking at can it happen in real life with all this, what we see the benefit from agent study or Keynote 671. Okay, but just to highlight, okay, so when we have MDTs, so MDTs, we have the pulmonologist, we have the surgeon, we have the radiologist, nuclear medicine specialist, we have the oncologist, we have the pathologist. So if you see different specialty, we'll look at different aspects of the patient. So the same patient, you look at different view. Of course, the pulmonologist is interested in getting the diagnosis, staging the patient. The pathologists are interested in knowing what is the histology type, what is the molecular mutations in this patient. And surgeons will look at the resectability, and oncologists will see whether these patients need any systemic treatment before they go for surgeon. So when you put all the brains together, you have a better outcome rather than working in silo. Okay? So the rationale is actually to see whether we can do this in real life and what do we do in patients who does not respond. Yeah, because not all treatment will then have the same effect in every patient. Some patients it works very well, they get PCR. Some patients have chemo-resistant or immunoresistant that it doesn't work. Okay, so this is the rationale of MDT Bridge. Okay, if you see the way it works is that how is it different is that they give chemo and immuno for 2 cycles, then they reassess, okay? So are these patients still borderline or is it resectable? So if it's borderline resectable or become unresectable, then the patient doesn't go for surgery. So they go for concurrent chemoradiotherapy. Those patients who are resectable then have another 2 cycles and then go for surgery followed by adjuvant immunotherapy after that. So MDT Bridge looks at how to bring all these studies, all these strategies into real life and how do they dynamically change the patient's journey based on the response of treatment. Okay, so I think I mentioned about that. So basically what I wanted to say is that early stage non-small cell lung cancer is no longer just for surgery, okay? So it's basically a more heterogeneous group, okay? It needs combination of many specialties to come and think about what is the best way to give this patient chance of cure. And number 2 is that giving perioperative strategies actually increases the outcome with PCR and also reduction in recurrence and progression, okay? And MDT, basically the patient journey is not owned by just one person, it's rather a collective effort, okay? With that, I thank you.
Thank you, Marfa, for the very nice overview of the perioperative trials that are available to us. So before we move into toxicity, I'm just going to spare a few minutes to talk a little bit about the MDT Bridge, which is, just let me go through here, okay? So I know it's a little bit more than what I said that we will talk about, basic, but it's very interesting to see how borderline resectable cases are being managed these days. I think this is a hot topic now, and we are going to face more and more discussions about borderline resectable non-small cell lung cancer because it's always been very difficult to decide which way patients go on to. So we have the Pacific trial, which is also a trial done by AstraZeneca, which gives concurrent chemoradiotherapy to stage 3 unresectable patients, followed by durvalumab. Okay, so that is okay, it's a bit different, but it's concurrent chemoradiotherapy up front, and then followed by durvalumab. And now there is this perioperative approach that we are also considering for stage 3 and borderline resectable or unresectable cases. So my first question is to Marfa, if we do this, we give, for example, durvalumab and chemotherapy for 2 cycles, and then we're going to give concurrent, chemoradiotherapy. Are you worried about toxicity? Because there's already a neoadjuvant IO there.
Yeah, true. But then in reality, the concurrent chemoradiotherapy, the evidence is that the patient go for chemoradio, actually the chemo would be about 4 cycles. So they can have it like before the concurrent chemo and then chemoradiotherapy. So we have had patients in the past with concurrent chemoradiotherapy having chemo upfront as well. So that's already toxicity from the chemo. But of course, with this, then you get the additional toxicity from the immunotherapy, and then radiotherapy also causes.
So how long would you wait before, immunotherapy lasts very long in the body?
Okay, so, but what we know about immunotherapy is that the toxicity tends to happen at a later stage. So normally, I think for pneumonitis, we're looking at 4 months. So 2 cycles is basically about 6 weeks. So I think that's one of the rationale that is still doable in this case. 2 cycles, that's 6 weeks. How far between the last cycle to radiation? Generally for chemo, we want 3 to 4 weeks. For immuno, the same thing, 3 to 4 weeks. I think is the washout period before we start.
And would we be expecting the chances of pneumonitis to be much higher in this population?
I think we need to have that awareness. Then early involvement of pulmonologists is very important. Early basically lower threshold to investigate if we see any as well.
Yeah. So back to Siva, I think I had a case recently that was referred to you, exactly same case, But I struggle, and I think a lot of oncologists would struggle as well, whether to add in. So we gave neoadjuvant chemo, and the patient responded, but it was borderline resectable. But whether to throw in that immuno in and upfront in during the MDT, whether to throw in the immunotherapy in, and then hoping that she will be resectable. But because if she goes into the unresectable, then we were like, OMG, what are we going to do at that stage? But you see, by not adding the immunotherapy, yes, we spare her from the risk of pneumonitis should she need the Pacific arm, but we cannot achieve PCR. So what is your view on that, Siva?
No, I think the key thing here is that to look at her lung reserve. If her lung reserve is adequate and she has got decent amount of lung reserve, then we can go on to extend our resection as safe as it can be. If she needs a bilobectomy, we do a bilobectomy. If she can tolerate a sleeve, we do a sleeve. The key again comes back to, like what I mentioned earlier, how comfortable the surgeon is in doing an extended resection. And I think now that lung cancer treatment is evolving, the surgeons who are involved in lung cancer treatment has to also equip themselves with the training in extended resection and complex thoracic oncological surgeries. So that will allow us to actually further, I would say, arm you guys around to do the complete treatment for the patient rather than we do a little bit and leave some behind, and it becomes very complicated later on. I mean, the key thing again, like I mentioned earlier, was R0. If you can't achieve that, then you shouldn't commit for surgery.
So Marfa, what do you think now that, Prof. Siva said that he would reset upfront in this, maybe more advanced stage, maybe borderline resectable, but how can we promote, or how can we, where is the role of neoadjuvant treatment in this? Because Prof. Siva said, I can resect, but then you may feel that and I also may feel that I want to achieve maybe a PCR or a 25% chance of getting a PCR in this.
Okay, so I think the question is between borderline and clearly unresectable. In borderline, we need to look at what does it mean by borderline? Are they like very heavy nodal disease? So if they are very bulky nodal, I'm more inclined towards giving some neoadjuvant. And whether if this patient won't get R0. So I think we are more inclined to do concurrent chemoradiation. Also looking at the disease pattern. If a patient has supraclavicular lymph nodes and a very peripheral lung primary, then it's very difficult for us to achieve our radiation goal because it's a very large field. So I think those comes into play as well, which one we would choose to go for unresectable, changing it to resectable with perioperative, or straight away go for the specific regime.
Yeah. Okay, so I think in the interest of time, we have 2 minutes left to 7:30. I promised we will finish at 7:30. I just wanted to ask any last comments from Marfa and Prof. Siva about any take-home messages for them.
I think the key thing here is that I think for everyone on the floor here, is lung cancer is no more a disease that can be said non-treatable. There is treatment options available for all stages, irrespective of when you arrive at your corridor. So when you all see, what I would advise is refer to the chest physician, oncologist, or even surgeon if you all don't know anyone to refer to, and then let them take it down their pathway with their teams and decide on what to do with the patient. And don't prematurely tell the patients you have got 6 months or 9 months to live when you see a patient with a lung mass and pleural effusion. Right?
I think maybe I would say MDT, 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 MDT. Yeah.
Okay. So we gave you a flavor of MDT just now as we were discussing cases, and that is how a MDT should be done. We respect to all of us, and we give our expertise, and then we come to a joint decision of what should be done for the patient. Okay, so with that, thank you very much for your attention, and I hope you enjoy your dinner later. Thank you.
Okay. Thank you, Prof. Ernest, and thank you to all our panelists for that valuable discussion. So cancer is no longer a diagnosis without options. I hope everyone agrees. And there is more hope today than ever before. I hope everyone agrees too. So, dear delegates, we would like to kindly request everyone again to take a moment to scan the QR code on the screen to complete a short post-event survey for COPD and severe asthma session just now. Thank you. All right, as we conclude today's scientific program, let's once again express our sincere appreciation to all our speakers and panelists for sharing their expertise, perspectives, and time with us. Their contributions have truly enriched our understanding and inspired meaningful conversations throughout the day. So please join me once again in giving them a warm round of loud applause. And to formally close today's event, it is my pleasure to invite Dr. Sonesh Kaura, Country Medical Affairs Director of AstraZeneca Malaysia, to deliver the closing remarks. Over to you, Dr. Sonesh.
I hope you can hear me now. Okay, great, perfect. So I'll follow what Prof. Ernest said. I'll keep it short because I'm standing between you and dinner. And also I'll keep it simple. So I just have to share two things today. But before I go on, I'll request another round of applause for all the speakers and panelists today. It's the weeks and days of hard work because of which we had a great event. So thank you all for your hard work. I'll just share two quick things with you. One is my takeaways from the whole day's event, and secondly, the future of AstraZeneca. For the first part, I'll just share, for COPD session, I think the key things that we took away was that exacerbation is a cardiopulmonary event. We should take it as serious as a heart attack, which we do not now, but I hope that we do that in future. Secondly, only less than 50% of the patients are alive after 3.5 years, which is even a worse statistic as compared to a heart attack. So I think we should take that seriously. And the second thing which I took away was that early initiation after an exacerbation is really important. From MOH, what we understand was that the diagnosis rate in our country is still very poor. For lung cancer, 85 to 90% of the patients are still diagnosed very late in stage 3 and 4. Hence, we are too late to treat. Similarly, for COPD, spirometry is only present in less than 20% of the hospitals. And lastly, the Lung Health Initiative will expand to 150 hospitals by end of this year and probably nationwide by next year. For severe asthma, it's still a very difficult condition to treat. And OCS is a major challenge. And lastly, as Dr. Mahfouz said, it's MDT, MDT, MDT. People have to come together, pulmos, immunos, and ENT to diagnose and treat severe asthma. And the same goes for lung cancer. We need a lung tumor board in every hospital going forward to treat it well. The second thing which I want to share is the future of AstraZeneca. As you see on the slide, we have around 47 clinical trials running in right now. By the time I speak, the number has increased to 49. And we have the highest number of clinical trials running in the country currently. Along with that, I'll take your attention to the blue color marks because those are the ones which are relevant for respiratory and immunology. If I go deeper into this, you see all of the drugs which are being studied. But to simplify, I would say what Prof. Martha said in the future, that the future is very complicated. All the drugs which are in asthma are currently being tested for COPD, and the other way around is also true. So for all of you, the future will be difficult, but I'm sure for patients it will be much more beneficial because they will have a lot of options. Similarly, if I share the pipeline for oncology, it is even more complicated as compared to the respiratory. But two drugs which I would share in particular to look forward to, other than osimertinib that we already have, is savolitinib, which is coming in MET amplification, as well as Dato-DXd, which is the first ADC coming in lung cancer. Hopefully, these will give more options to you as well as your patients. With that, I thank you for this event. This will be added to all of these events that we have done year round, and hopefully we continue this partnership. Thank you so much.
Thank you very much, Dr. Sonesh. Today's discussions and shared insight have indeed highlighted the importance of collaboration across discipline to improve respiratory and lung cancer care, ultimately advancing patient outcome in Malaysia.
On behalf of AstraZeneca, we would like to extend our heartfelt gratitude to our chairpersons, moderators, speakers, panelists, and guests for your participation and valuable contributions.
Before we conclude, we greatly value your feedback. Once again, please scan the QR code displayed on the screen to complete one last feedback form. We hope you have found today's sessions informative, engaging, and enriching. Please be informed that for CBD points, submission will be processed manually by the organizing team after the end of this event. Please also remember to validate your parking at the ballroom foyer for the flat rate of 16 ringgit per entry.
Ladies and gentlemen, dinner is now served at Latest Recipe Restaurant on level 5. We'd also truly like to apologize for the shortage of refreshments during the break earlier, but be rest assured that there's plenty of dinner prepared for everyone. On behalf of AstraZeneca, thank you for joining us this evening. Enjoy your dinner, have a pleasant evening, and we look forward to seeing you again.